Hi, everyone. Welcome back to our NCLEX review session for today. I will be handling another topic and we'll be focusing on the central nervous system disorders for the meantime. And we'll be talking about the seizure disorders today. But before we're going to go into that topic, I really want to thank everyone for being a regular attendee for the review sessions that we have. And for those who just started joining us, and for those who are newbies, we are encouraging you to check out our website at www.stancoast.com. And please check out about our nursing course, our NCLEX program. And this will be available for the entire 6 months with your subscription. And there's an updated library we have for the recorded videos and also the animated videos, plus the NGN test questions. We have the 3000 NCLEX-style questions as well. And of course, we really want to hear from you about your feedback as well in our lectures. We'd like to know more about your comments. And of course, if you have any questions, please don't hesitate to type them in the chat box, or it could be in the comment section. So, we are again doing this review sessions for the 90 days, and we are on the 48 days. And again, we are encouraging you to like, subscribe, and also share this video if you find this helpful. All right. For those who just came into the classroom, welcome everyone, and hope that you can hang tight with us all throughout the session. All right, let's talk about the seizures. Well, you've already seen this one, right? So let me just launch everything. Now, let's talk about the seizure. It's basically a disorder in the nervous system, and it's very important for you to understand about the general characteristics and also the possible complications that may arise in a patient that may have a seizure disorder. And as you see here, that a seizure can occur as a result to what? An abrupt and also an unusual burst of electrical impulses in the brain. And this can really manifest in so many ways. It could range from convulsions, maybe loss of consciousness, or it could be subtle moments of just simple stare and confusion. So there will be different types of seizures that you will be knowing today. Now, epilepsy, however, is another term which refers to a condition when someone can experience recurrent seizures, and there's not really a clear underlying cause for the seizure, or let's say the epilepsy. Now, as you see here, there are several causes or contributory factors to the occurrence of a seizure, and we have here the 4Ms and the 4Is. So what are these 4Ms? Well, as you see, there's that metabolic and electrolyte disturbances. And the most popular electrolyte disturbances or disturbance that can cause the seizure episode will be the low sodium level. Okay, so I really want you to recall the concept in fluids and electrolytes, especially the normal levels, because it is a very common issue, especially in our patients. So any patient that may have a reduction in their sodium level, less than 135 milliequivalents, and when it goes lower than that, let's say in the 120s, 116, 118, our patient will be at a higher risk to develop the seizure episode. Okay. Now, another one is water intoxication. So in a case wherein the person might be drinking way too much water, maybe 4 liters in one sitting, this could really dilute their system. It can cause delusional type of hyponatremia, wherein the patient's level will be somewhat, it's going to be diluted. And of course, as we know, that sodium is also a vital electrolyte in the transmission of impulses, especially in the brain cells. Now, we also have hypoglycemia, or it could be hyperglycemia. This is another issue that might contribute to the seizure, especially if the glucose will be less than 40, 30. Our patient around that time will be somewhat somnolent, obtunded. And if it goes to that certain level, the dangerous level, maybe around the 20s, 25, our patient can go into a seizure episode when they're not getting the adequate amount of glucose to the brain. And yeah, they're gonna have this episode. And the same thing with hyperglycemia, but more often, it can happen to the hypoglycemia. But again, in some cases with severely high glucose, it can also lead to the seizure. Now, another is hypocalcemia, as we know that this is an important electrolyte, especially with, it has a function with the tone of the muscle. It can also assist in the contraction of the muscles and also in the transmission of the impulses. So if there is hypocalcemia, it can likely lead to the seizure episode as well. So this is an important electrolyte that needs to be evaluated or looked into, especially when the person is a new patient to an organization or a hospital and there's no definite history. And so the medical provider would have to order the calcium level along with the sodium, sugar level as well, in order to determine really what is precipitating the episode. And we also have uremia, of course, our byproducts or the byproduct of protein metabolism. If there is a buildup of those BUN, also creatinine in the bloodstream, it can cross into the blood-brain barrier. It can also lead to that seizure episode. And the same thing with thyroid storm and hyperthermia, especially in children, right? For those who have the febrile type of seizure, there is going to, that complicates into a seizure episode as well when the patient's temperature is very high, okay? But hyperthermia or the febrile type of seizure is not going to be our focus of the discussion today. That will be more in the pediatric nursing. Now, another is the presence of lesions, especially in the brain. If there is a presence of mass, it will occupy a space. So it could be a primary or maybe a metastatic type of a lesion or a mass that could possibly occupy a good amount of space inside the brain, and it can increase the intracranial pressure as well, right? And the same thing with maybe a brain bleed. This can also disrupt the brain activity and will lead to the seizure. Now, this one right here, guys, missing drugs. This is a very common cause of seizures, especially in those people or patients that may have a history of the seizure. Okay, so if they're not being compliant, if they're not really taking their medications on schedule, then what can happen is that their drug level, okay, the medication level in their bloodstream will somehow become subtherapeutic. Okay, what do you mean no sound? Can you please confirm, guys, if the sound is not working today? Because I think my sound is working fine. Can anyone confirm, please? All right. So, subtherapeutic medication levels. All right. So this is something that will need to be checked as well in the case wherein the patient comes into the hospital with seizure episodes, and if there is no clear indication, maybe there's no enough information about this patient, maybe this is the first time the patient has come into that facility, then definitely there's the medical provider might decide on checking the medication level as well of what that anti-seizure medications that they have been taking, and so that needs to be checked as well to check for the therapeutic level. Okay, wonderful. Thank you. Now, there is also the acute withdrawal to some substances, especially alcohol or maybe benzodiazepine. So if the patient have been taking these substances for quite a long time, and if they're going to stop suddenly taking these substances, especially alcohol or the lorazepam or diazepam or barbiturates, without consulting their medical provider, and this can really cause some acute withdrawal, and this can cause seizure as well. It can provoke seizure. And alcohol is a very common substance that people would use, and if they probably stop drinking because they run out of money. And so this can also lead to that delirium tremens. The person will go into that seizure episode, okay? And along with that, there's going to be fluid electrolyte imbalances. So you're going to look into so many aspects of the patient's medical history, look into their labs as well, check into the frequency of how often they are going to have this alcohol withdrawal symptoms, okay? Because sometimes it can happen within maybe several times in a year. I've dealt with so many of alcoholic patients that end up in the hospital because of the withdrawal symptoms, and seizure is one of those. Now, let's talk about the miscellaneous costs, the fourth M. All right, so we have first M, second, third, and fourth, the miscellaneous. So this can include those pseudo seizures, and this is associated with psychiatric disturbances, okay? Pseudo seizures. And again, they are of psychiatric origin, and the events that they will manifest will mimic the seizures, but don't really stem from the electrical brain activity. Now, in OB, I'm sure that you are familiar with the eclampsia, right? This is a condition, especially in those pregnant women with severe preeclampsia, or let's say when they're going to have that eclampsia. Basically, this is the pregnant woman that has hypertensive crisis plus the seizure episode, okay? Eclampsia. And they really need to have much more of medical attention immediately in order to control the seizure. And again, I'm sure you're familiar with the magnesium therapy, right? They're going to receive that infusion in order to stop the seizure. Now, there is also a miscellaneous type of seizure, which is based, or cause of seizure, which is the hypertensive encephalopathy. Okay, hypertensive encephalopathy. So what is this? Well, when this happens, the patient will have an extremely high blood pressure, and it can lead to brain swelling. Of course, the ICP here will be increased, and it will lead to the seizures. Now, looking into the four I's here, we have the following: intoxication, infection, ischemia, increased intracranial pressure. So here we have intoxications of the following substances. We have cocaine, lithium, lidocaine, theophylline. We also have the carbon monoxide. These are known to cause seizures, especially. And for the infections, we have septic shock, or septicemia could be caused by a bacterial or viral meningitis, or it could be caused by an abscess in the brain. Now, for those patients that may just had a stroke, or let's say a transient ischemic attack, yes, they are known to have a complication, which is the seizure, because of the reduction in the blood flow to the brain. And this can also initiate the seizures, particularly in the elderly patients. All right, this is common in elderly, and I'm talking about the seizure episode, not the TIA or the stroke itself. Now, of course, lastly, we have the trauma, which can lead to the intracranial pressure as well. We know that whenever there is maybe displacement of the brain tissues, maybe a skull fracture that may have caused excess pressure into the cranium, this can also increase the intracranial pressure, which can complicate into the seizure episode. Okay, so I hope that you are now have a better understanding for those common causes. Of course, don't forget the 4 M's and the 4 I's. We have the metabolic electrolyte imbalances. We got the mass lesions, missing drugs or substances, the miscellaneous contributory factors. We have the 4 I's: intoxications, infections, ischemia, and increased intracranial pressure. Now let's talk about the seizure disorders, and we will be classifying the types here. We'll talk about the partial, or let's say the focal seizures, and the generalized seizures. Let's tackle first the focal or the partial seizures. And this is a common type of seizure, especially for those older than 18 years old. It can occur at any age greater than 18. And it is about 70% of patients have this kind of seizure problem, okay? Most people, it actually comprises about 70% of seizures. Okay. Now, we're going to have to describe the partial or focal seizures according to the following. Let's start with the age of onset. Now, again, like I've said, this can occur at any age from any age. So it could occur from infancy to adulthood. But under the focal or the partial seizures, it's actually classified into two. Okay, there's what we call a simple partial, and the other is the complex partial. So let's just go through comparing the different types of focal seizures. So for the simple partial, it can occur at any age. For the complex partial, it can occur anytime during childhood, or it could be adolescence. And they do not really have a specific age of onset, right? Because of maybe various factors, maybe brain injury, could be infections, or maybe genetic predisposition. And as far as the hemisphere, let's talk about the involvement of the, hello everyone, welcome for those who just came into the classroom. Let's talk about the hemisphere. We're going to talk about what is the involvement here. So for the simple partial, both of these types actually will have the effect into just one hemisphere. I mean, the origin where the seizure occurred specifically will be confined into just one hemisphere of the brain. And the same thing with a complex partial seizure. It also involves just one hemisphere of the brain. It simply means that the onset, or let's say the initial abnormal electrical activity, is confined to a small region before possibly spreading. Okay, so again, talking about focal partial seizures, it can occur in one hemisphere. Let's talk about the triggers. What could possibly trigger both types? Well, this can be caused by the stress, the lack of sleep, or it could be exposure to flashing lights. And the same thing will occur with the complex partial type of seizure as well. And these triggers can actually lower the seizure threshold, especially for those susceptible individuals, and making the seizure much more likely to occur. So imagine these: stress, lack of sleep, flashing lights, and if they have already a history about the focal seizure, yeah, this can really precipitate the episode. Now, let's talk about another characteristic here about the aura. So, looking into the different types of the focal or the partial seizures, the aura is going to be present, often present in the simple partial, and it can also lead to this unusual kind of sensations. All right, so what do you think about the aura? The aura, basically, it consists of an unusual sensation, or maybe unusual feeling that can result of the initial electrical disturbance in the brain. And maybe the person here will also have visual disturbances. Okay, so think about this aura. This is very common in this type of seizure. Okay, focal seizures, partial seizures. The aura is a common characteristic. So what are these aura? Maybe the patient will have some visual disturbances. Maybe they will have that kind of strange smells, or maybe they will experience that very unpleasant taste, or maybe a feeling of deja vu. Okay, so this is very common between the partial, simple partial, and the complex partial. Now let's talk about the symptoms, the manifestations of this patient of focal and partial seizures. Now, what could be the following manifestation, especially if we are talking about sensory symptoms? Well, they will feel the tingling sensation, maybe numbness, or maybe some unusual sensations in one part of the body, or maybe just a specific part of the body. And they're also going to report that, or this is going to be seen, especially motor symptom, wherein the patient will have the jerking movements. And it could be the arm, or it could be the leg. And in some cases, they also have that heart changes as well. They will have irregular or maybe variations in their heart rhythm in a small time frame. Maybe they're going to experience also the hallucinations, sweating, and also nausea. Now, comparing the simple partial with a complex partial type of seizure with the manifestations, here in the complex type of seizure, they're going to be more confused and much less awareness about their surroundings and also the events. And they will also have they would not be able to recall really what has happened in their surroundings. So they will get confused, they will get disoriented. Now, classic to the complex partial type of focal seizure, they're going to have those repetitive behaviors wherein they're going to start lip smacking, or maybe they're just being fidgety. Okay, so those are what we call as automatisms. Again, this is only common to the complex partial focal type of seizure. They're going to have lip smacking. They might have that persistent chewing, even if there's nothing really in their mouth. They will get fidgety, or maybe they will be walking in circles, all right? Or hand movements as well. Now, again, this will differentiate between the complex partial and the simple partial. So this is only common to this subtype of seizure. Now, let's talk about the duration of the seizure episode between the two. Well, for the simple partial, typically it can last for seconds to a few minutes. Generally, it can be brief, or it can be prolonged in some cases, but more commonly just going to last in seconds to a few minutes. Now, what about the complex partial? Well, it's going to be about 30 seconds to 2 minutes. So not a lot of variation here, but again, the person in the complex partial type of seizure, they will have that distinct confusion after the episode. Confusion. Let me rewrite that. Confusion and also fatigue. So this is distinct in the complex partial type of seizure. Now let's talk about the level of consciousness in these two types. So what do you think will be assessed in a simple partial type of focal seizure? Well, they are fully conscious. The person here will be fully awake during the seizure episode. They are aware what's going on in their surrounding, even though they might experience unusual sensations or movement. So they are fully aware. They're not unconscious, okay? They are fully aware of their surroundings and all those unusual sensations that I've mentioned, okay? Could be that bad taste or smell. So that can be assessed in this type of seizure patient. However, in the complex partial type of seizure, they're going to have impaired level of consciousness, and the patient may appear awake, but the person is not really aware about their surroundings, and they probably will not respond normally and may not have any recollection of the seizure episode. Okay, again, there is impaired consciousness. There is confusion. They will not have recollection about the events at all. Okay, so this is distinct in the complex partial type of seizure. Again, guys, the partial or focal seizure is a main type of the seizure, and it has two components or two subtypes. We have the simple partial and the complex partial. Alrighty, and it occurs mostly about 70% of all seizure patients. Okay, 70%. Now let's talk about the generalized type of seizure, which is another huge family of seizure type. Okay, now here we will be describing the different types as well. It is quite longer compared to the focal or partial seizure, and we'll talk about the tonic-clonic type of seizure. So what is this? Well, this is going to last for the few seconds, maybe tonic episode, and the patient will lose some consciousness. So the tonic-clonic is what we refer as the grand mal seizure, wherein the patient will be convulsing, both tonic and clonic. And again, it will start within a few seconds for the tonic episode, and the patient will proceed into this loss of consciousness. So it starts with that. Again, few seconds of tonic episode, and this will proceed into the loss of consciousness. And when the person proceeds into the clonic episode, it will last for about 1 to 2 minutes. Okay. Now, another thing that you can see in this patient is that during the tonic episode, their breathing may stop. And so you really need to observe this patient if in case this happens in the acute care setting. If you're taking care of this patient, you really need to observe the duration and also the overall state of your patient. Is the patient looking cyanotic this time? So you really need to pay attention into the airway as well. They're going to be irregular breathing once they reach that clonic episode. Okay. Now, what about the cyanosis? So what is this? Basically, a change in the color. There will be bluish purplish discoloration in their skin because of the hypoxemia. And it can also involve the biting of the cheek or the tongue. And this can also somehow block their airway. So you got to be careful with this patient. And this might also include incontinence, maybe urinary incontinence or maybe stool incontinence. So these are all known descriptions about the tonic-clonic type. Now this time we'll talk about the tonic. So what is the tonic? So specific, it just involves the tonic episode. So here the patient will have sudden loss of consciousness, the same thing, and there is going to be increased muscle tone. Okay, just stiffening, muscle tone is increased. Now, there could also be loss of consciousness in this type of seizure, and there can be irregular heart rhythm. They might end up with cessation in their breathing. Could also involve vomiting after the episode, or also incontinence and salivation. So you got to be really careful with their airway. Again, they will not be able to manage an open airway around this time. So take a look into the autonomic manifestations: irregular heart rhythm, apnea, vomiting, incontinence, and salivation. Now, what about the clonic type of seizure under the generalized seizure? Well, it only comprises the clonic phase only, and this is going to last for several minutes. So you really need to time the duration, right? Because if you are not able to capture the onset or the time of the seizure episode, you will not be able to tell the exact duration. And as we know, if the seizure persists more than about 5 minutes, there is a risk of brain anoxia, right? And this can lead to permanent brain problems. There could be irreversible impairment if we are not treating the seizure. Now, this is going to include both the contraction and relaxation of the muscles as well. Okay, so this is on the clonic type of seizure. Now, for the myoclonic, what is this? This is going to display brief jerking movements or stiffening of the extremities. And this time, this can only last for a few seconds. So the person basically here will be fully conscious. Very brief. While the others in the generalized seizures, most of the time they are unconscious or they will lose consciousness. Now let's talk about the myoclonic as well. There is a danger in falling because of the stiffening in the extremities. So they are a high fall risk for this kind of seizure, right? Now, there's another one, atonic or the akinetic type of seizure. This is going to only last for a few seconds, and muscle tone loss. So imagine if this person is ambulating in the hallway and all of a sudden they will have the atonic, akinetic type of seizure. They're going to drop on their face. Another fall risk patient here. And there's also confusion after the episode. And then lastly, we have the absence or the petit mal type of seizure. This is a very old term, petit mal, and this is going to involve a sudden and staring spells for about 15 seconds. So the patient is just kind of like stuck to staring in one spot, and this might be mistaken as simple daydreaming, but it isn't daydreaming. They're basically having that staring spells, and this is what we call as, again, the absence. They will stop moving abruptly, and they will just stare into just one direction for about 15 seconds, or it could be lesser. And this is a type of seizure that can resolve on its own, even though the person may not fully remember what happened during that episode. But their state of alertness actually will return immediately afterward. Okay, so patient doesn't develop unconsciousness. They are actually awake, but doesn't have any recollection about what exactly happened during the seizure episode. So this is just blank staring, similar to a daydreaming. Okay, now let's talk about the diagnosis of the seizures. We're going to go directly in this section. So there are so many tests that will be involved, especially in diagnosing a seizures. Now, what are those testing? Well, of course, if there is a suspicion that maybe the client or the patient may not adhere to the medication regimen, or maybe they're just, I just can't afford to buy the medication, so they probably stop taking the drug. Even though they have known history of repetitive seizures or recurrence of the seizures, they will eventually stop because they just can't afford to buy them. And so one of the diagnostic tests here is to perform welcome back, Jet. I hope that you're all safe there with your family from hurricane. Oh boy, that doesn't sound good. Now, we'll talk about the drug levels. Okay, so this is going to be intended, especially for those patients with known disorder, seizure disorder. If they have an established diagnosis in the past, then this is very important. When they come in to the hospital for a seizure episode, there's going to be checking of the drug level to see if it's therapeutic or subtherapeutic, or it could be toxic, right? Now, it is very important, especially to check the drug levels, like the Dilantin or the phenytoin, or it could be the carbamazepine. These medications can actually have, or they have a very therapeutic range, narrow therapeutic range. So again, these are the drugs that can potentially cause toxicity to our patient. We have the phenytoin, carbamazepine. They are known to have a very narrow therapeutic range. So regular testing of this drug level, especially for the new patient being prescribed the phenytoin or carbamazepine, they need to have regular testing, especially during the early phases of the therapy. Okay. And again, of course, they're going to need to have their blood drawn every now and then to make sure that they maintain the therapeutic levels to avoid the seizure recurrences. Now, another testing will be, it will include the checking of the complete blood count, could be the electrolytes, the liver function test, the kidney function test, or the checking of the serum calcium. So let's talk about the CBC. Well, with the CBC, showing the white blood cell count, it might detect if there is an infection. Okay. As we know that this is basically one of the I's, right? Infection could be the root cause of the seizure, or it could be anemia that can also affect the brain function. So these are helpful lab values as well, even though they do not directly aid in the diagnosis, but they can also pinpoint some major issues that patient might have. Now, another thing that might be seen in electrolyte, especially if there is an imbalance, what do you think about the electrolyte? So, for example, if there is sodium depression, or let's say hyponatremia, like I have said earlier, if the sodium drops severely low, maybe in the 120, less than 125, yeah, the risk of seizure episode will be higher in this patient. Anything less than 125 milliequivalents per liter. And I've encountered way so many elderly patients coming from their nursing homes or assisted living coming into the hospital with seizure episode because of the low sodium levels. I've taken care of patient as low as 112. Like, really? Why? 112. Yeah, that's quite low. And you got to be careful, especially in replacing the sodium level in this patient. You do not want to treat them rapidly, giving them hypertonic solution. No, there is going to be a protocol how to safely replace the sodium in this patient. Okay, there is that what do you call this? Progressive slow replacement in order not to cause any neurological problems. And we will talk more about that kind of syndrome that can occur, especially with a rapid treatment in hyponatremia. And again, hyponatremia is another electrolyte imbalance, especially if it's severely low. It can lead to seizure. Now, another thing that might add to or contribute to the seizure is the low blood sugar, hypoglycemia. Low blood sugar. For example, maybe the blood sugar is less than maybe 30, 20 milligrams per DL. That's very low. The body will not be able to supply nutrients to the brain cells, and so they're gonna have that seizure episode. Not fun. Now, let's talk about the LFTs, the liver function tests. LFTs. As we know that the liver basically is the main organ in the body that will metabolize, it will process the medications. And if there is going to be a problem in the function of the liver, then what do you think can happen to the metabolism? Maybe the medication level will be too high because it's not processed properly by the liver. Yeah, it can cause toxic effects of the medication as well. So you really need to pay attention into the liver function test, the AST and the ALT, before initiating the anticonvulsant drug. All right. Now let's talk about the renal function test. Well, this will pertain to the regular creatinine level, right, and the BUN, or it could be the EGFR, creatinine clearance. This is very important, guys, to have because most of the anticonvulsant medications will be cleared through the kidneys. And if there is impairment in the renal function, there's going to be increasing half-life. If there is renal impairment, it can cause drug toxicity. The medication level will be too high because of the decreased excretion of the drug. If it's no longer used by the body, definitely it needs to be excreted. But if there is renal failure, the patient will tend to collect or accumulate the medication, causing toxicity. All right. And here is the half-life will also play a role here. Remember about the half-life, wherein it will tell us the elimination of that drug every minute, every hour. And again, if that medication is known to have a long half-life, and let's say the kidney function is impaired, well, the medication will stay a lot longer in the system, again, causing toxicity. And also, we're gonna need to check for the urinalysis of the patient to check for any signs of infection or maybe metabolic issues that could possibly trigger the seizures. All right, guys, again, we have a reminder we have from Boss Babe. Thank you, Boss Babe. Please hit the like button for others to join the class. Wonderful, thank you. Thank you so much for the suggestion. Mary Akugri, CT scan, EEG, serum, electrolytes. Yes, those are the other diagnostic tests that we will also be talking about. So moving on forward here, let's talk about the serum calcium. Oh, I forgot about the serum calcium. Basically, that would be also needed because we know that when there is hypocalcemia, it can affect nerve signaling and also will lead to seizure. Okay. All right. Let's talk about the EEG. What is that EEG? The electroencephalogram. So this is a test actually, or diagnostic test that will be helpful in the diagnosis of a seizure disorder. So you probably would be asked in the NCLEX, what would be your nursing action when you're going to prepare this patient for the procedure? Well, what you're going to need to do for this patient is to explain what the procedure is all about. You're going to probably talk to them in very simple terms. Hey, this is the test that the doctor has talked about. And I'm sure that you probably have talked with a doctor regarding this diagnostic test at length. So just want to make sure that you have some retention with the information. So basically, you're going to have to make sure that the patient is aware that they have this kind of diagnostic test ordered for them, and you will just be supporting what the medical provider has instructed them or what the risk and the benefits are for the procedure. So you're going to have to do some education as well. So part of the preparation here will be to instruct the patient to wash their hair thoroughly before the test in order to remove those excess oils, hair oils, or it could be the gel, spray. And this can possibly interfere with the placement of the electrode. Wash hair, the scalp thoroughly. All right. So it could be the nurse aide doing this, or if the patient is able to do it by themselves, then make sure that you instruct them really how to prepare their scalp or the hair. Again, this is to remove excess oils, the gels, sprays that might interfere with the electrode placement. Now, what is the importance of the EEG? What can it show? Well, in a seizure patient, it might show some abnormal brain waves that may indicate the epilepsy. Even though the patient appears very normal between the seizures, it can capture those. And with a normal EEG, after the first seizure, it can possibly suggest a lower risk of recurrence, right? So if the EEG looks normal, then possibly the patient probably will not have any recurrence. But if they have any abnormal activities, then possibly this patient might have a recurrence of the seizure. Now, another testing that you might see in the order will be the head CT of the head CT. Okay, this is going to capture any structural abnormalities in the brain. Detects structural abnormalities in the brain, and maybe presence of tumors, maybe stroke, or could any shifting of the tissues inside the brain. It is very quick in determining the issue, the structural issue in the brain, especially during an emergency. But again, this is going to be less sensitive compared to the MRI. Now, talking about the MRI, this is going to give us a much better picture, images of the brain tissue and structure, and it is much more sensitive in detecting those very subtle abnormalities inside the brain. And another testing that you might have encountered in the past is the lumbar puncture, okay? So I want you to recall the exact procedure, how you're gonna help this patient during the lumbar puncture. You're gonna, of course, explain the procedure to the patient. Even though the doctor has explained the procedure to them, you're gonna have to just kind of reinforce and also assess if they do not really understand what the procedure is about. This is an invasive procedure. This will require consent signing, okay? Consent is required. And you will be assisting the patient possibly around this time if you are assigned to help in the procedure room, if maybe at the bedside. This can be done at the bedside as well. And you really need to position the patient in that appropriate C position, just like a patient positioning it like a shrimp, right? To expose that vertebra and also that appropriate level of the vertebra. And the reason for doing the lumbar puncture is to examine the CSF for any signs of infection. Assesses the CSF for what's going on with my handwriting today. CSF for infection, or if there is inflammation going on, this has to be evaluated as well. And also, if there is a suspicion that there is really infection, then the cultures will be obtained as well. Cultures to check if the patient may have a systemic kind of infection. Okay, so these are the most common diagnostic tests again: anticonvulsant level, the CBC, electrolytes, LFTs, renal function tests, serum calcium. These are more of supportive tests. Whereas we have the EEG, we have the head CT scan, the MRI, in order to detect any structural issues for the head CT, MRI, EEG for the brain, abnormal brain activity. And the lumbar puncture is to assess for any kind of inflammation or infections that could affect the overall system, okay? So that's about the diagnostic test. Oh, there's more blood cultures, of course. If there is an ongoing infection that could potentially reach the blood-brain barrier, yeah, that could lead to the inflammation as well. Yes, we need to identify the microorganisms that have caused the seizure. Now, let's talk about the pharmacotherapeutic agents. And this is going to be an overview of the pharmacologic agents. And as we know that there are several types of seizures, right? It could range from being mild blank stare into a convulsive type of seizure. And we really need to know the differences of those, because each medication will be intended to that specific type of seizure. Not all the medications will be effective in treating the other types of seizure. Now, let's talk about the pharmacotherapy. What is this? Well, basically, this is going to include all those anti-epileptic drugs. AEDs, anti-epileptic drugs. So making that short. So The administration of the AEDs is really the cornerstone in the treatment of the patient's seizure. And this is going to be chosen based on the kind of seizure and what the patient had experienced. Now, talking about biofeedback, what is this? This is going to help in treating the seizure, which is a non-invasive technique. It will teach the patient to control physiological processes, let's say the heart rate, their blood pressure, the muscle tension through monitoring and feedback. And I never had encountered a patient having this kind of treatment. Maybe in a much more sophisticated institution or maybe higher level of neurological floor, maybe they will have it. But myself, I haven't encountered this kind of treatment. Again, this is a non-invasive kind of therapy. It will teach the patient to control their physiological processes like heart rate, blood pressure, and also muscle tension. So the overall goal here is to basically decrease the level of the tension, the muscle tension. Now let's talk about surgery, which is going to be, this will involve many things. This is going to be considered for those patients that may not respond to the anti-epileptic medication. Indicated for patients not responding to AEDs. The anti-epileptic drugs. So they definitely need to have some invasive procedure to remove a diseased part of the brain. Okay. Now, let's have a quick break. Just promoting our NCLEX program at our website. Please drop by at our website at www.stancoast.nclexcoaching.com, and also please check the description box below for more details. And of course, we have updated the library of our on-demand videos, both the lectures and also the anime videos. We still have more resources for you to offer. We have audiobooks, flip books. We have 3,000 NCLEX questions and also the 200 NGN type of questions. So again, please check out our website. All right, thanks. Now let's move into the discussion about the surgery. So one of those procedures are the following. There is what we call as the anteromesial temporal resection. So what is this kind of procedure? This is going to remove the temporal lobe or maybe part of the temporal lobe. Removal of the temporal lobe. Or it could be just the part of the temporal lobe. And this is going to be very effective for those patients with temporal lobe epilepsy. All right, of course, it has to be, there should be thorough diagnostic tests before this can occur, right? This is a life-altering type of procedure, specifically the removal of the temporal lobe. So there will be extensive batches of diagnostic tests before this procedure can be done to make sure everything is cleared. Now, another surgical procedure is what we call as the corpus callosotomy. So what is this procedure? This is going to allow severing the corpus callosum, which basically connects the brain into the two hemispheres. So this will be indicated to prevent the seizure spread between the hemispheres. All right. The purpose is to prevent seizure spread between hemispheres. And I forgot to mention about the generalized seizure. Actually, it will occur in two hemispheres, right? Whereas the other one, the focal or the partial seizure, will originate within just one hemisphere. So that is the difference between the two. Again, the generalized seizure will happen, or it can originate in two hemispheres, whereas the partial or focal seizure originates in just one hemisphere. So since This is going to prevent the spread of the seizure between two hemispheres. This is going to be effective in the patients with severe generalized seizures. Okay, so this is indicated for those patients with severe generalized seizure, corpus callosotomy. Now let's talk about the next surgical procedure, which is the hemispherectomy. So this is going to involve disconnection, or let's say removal of one part of the hemisphere of the brain. And this is going to be reserved for those severe cases wherein one hemisphere causes very uncontrolled seizure. Okay, again, this is only indicated for the severe case of epilepsy. And the reason for that, it's because maybe one hemisphere causes uncontrollable seizures that can really impair their ADLs. Okay, so again, hemispherectomy, it is going to involve removal of one hemisphere of the brain. Remember, one hemisphere, that's quite a huge area of brain tissue being removed. Yeah, I don't want that. No, just kidding. Yeah, that's quite extensive type of procedure when there is a removal of one hemisphere. Now, another treatment here is the stimulation surgery. So what is this? This is going to be indicated to those patients that are not good candidates for the traditional surgical procedures, or for those patients that may continue to experience those seizure episodes even they are taking the AEDs or the anticonvulsant medications, or maybe they're not really responding to the other procedures like the surgery. So this is basically a alternative treatment. Now, what are these stimulation surgery? Well, it can include the vagal stimulation or the placement of the vagal nerve stimulator, or in what we call as the VNS, vagal nerve stimulation. So this is going to involve the implantation of that device into the brain, and it will actually send regular electrical impulses to the brain via the vagus nerve, and the impulses can actually help reduce the seizure frequency, and it can also reduce the severity by kind of slowing down. It will also modulate the brain activity. Slows down brain activity. Okay. It will send much more regular electrical impulses to the brain via the vagus nerve. Remember about the vagus nerve? This is basically going to cause slowing down of the impulse transmission. Remember about that vagus nerve. So this implantation could definitely help that out as well. Now, another stimulation surgery is the intracranial stimulator or neurostimulator. So what is this? This is much more of a newer type of procedure wherein a device is going to be implanted in the brain, and this will also help monitor the electrical activity continuously. So isn't that kind of cool that you have an implant in the brain to maintain or to monitor the activity inside the brain, especially the electrical activity? I'm quite interested to have that so I can see my own brain waves or the brain stimulation. That's weird. And it also can deliver electrical impulses at very precise intervals in order to interrupt those abnormal brain signals. So this is pretty cool. Intracranial stimulator. It will deliver those electrical impulses at very precise intervals in order to stop those abnormal brain signals. So that's about the intracranial stimulator. Ooh, here's another. So let's talk about the different pharmacological medications or the pharmacologic treatment for this patient with the seizure problem. So you'll see here that I already put in here the different mechanisms of the drug. So how are these drugs going to control the seizure problem? Well, Well, there are 5 different mechanisms. The first mechanism you're seeing is the suppression of the sodium influx. Okay, so if it does that, it will block the entry of the sodium into the brain cells. So we have the examples here of those medications that can suppress the entry of those sodium in the brain cells with the phenytoin, the carbamazepine, the lamotrigine. So in the normal physiology, guys, I'm just going to give you a quick, very quick review about the role of the sodium and the neurons. Well, as we know that the neurons, those nerve cells, can send those messages using the sodium channels. And let me just put a representation here. Brain cells. Let's just pretend that is the brain cells, and this is the sodium channel. Okay. Now, the person, in the normal physiology, the neurons basically will send the messages from one neuron to the next using the sodium channels. Now, this can allow the sodium ions to create the electrical signals. But when the patient has a seizure, this medication, or those that can suppress the sodium influx, can stick to these channels. So the sodium channel basically will be blocked. Okay, so this will no longer allow more entry of the sodium ions into the cells. Again, suppression of the sodium influx will involve blocking of the sodium channels. It will prevent more entry of the sodium ions into the nerve cells. And so it can help calm down the rapid firing of the neurons. So if there is less entry of the sodium into the brain cells, this can lessen the firing rate or the amount of stimulation within the neuron. Okay, again, there will be decrease in the firing of those impulses. That's why it can work effectively for this patient. Now, what do you think what kind of seizures will be indicated for these medications? Phenytoin, carbamazepine, lamotrigine. These are going to be effective in treating the partial seizures. Okay, let me just put SZ. Or it can also be effective in treating the generalized type of seizure. Okay, or it could be the absence seizure as well. So take note of that. It can be effective in treating the partial seizures, the generalized type of seizure, and also the absence type of seizure. Now, let's talk about the suppression of calcium influx. What is this? Well, it works similar to a calcium channel blocker, but we are talking about the brain cell this time. And so with this medication, like the ethoxyximide, this is going to prevent the release of the neurotransmitters, and it can also lower the activity of the brain cells, and it will also control the seizures. Okay, so this is basically going to reduce the release of the neurotransmitter. So we have the ethoxyximide. Now, what is the use of this medication? It can treat primarily the absence type of seizure. All right, or this is what we termed as the pitimal type of seizure. Pitimal seizure. Okay, now let's talk about the promotion of potassium efflux, or let's say the exit of the potassium from the brain cell or the neuron. So in the normal physiology, normally the neurons are supposed to allow the sodium ions, right? It will allow those sodiums to come into the brain cells, and it will cause them to become excited. All right, again, in the normal physiology, it will allow the entry of the sodium ions to get inside the cell through the gateway, through the channel. And once that sodium gets into the cell, the neuron will become excited. So now it's able to send impulse from one neuron to the next. But after this initial activation, the potassium will also flow out from the neuron. Okay. After the entry of the sodium in the neuron, the potassium will also exit from the neuron, and this will help in the reset of the repolarization. Okay. So this is a very important aspect in the neurotransmission, because the repolarization is important for the neuron to be ready to fire again when needed. Okay. So this mechanism basically will protect the abnormal mechanisms, right? So there is a need for the potassium to exit from the cell once the sodium gets in, because if it doesn't, then the cell will be so hyperexcited. There is going to be a higher risk to develop the seizure. Now, the role of the medication, the ezogabine, this is going to enhance the potassium exit. All right. This will support the repolarization process. Now, again, the reason for this medication that it's going to be helpful, because it will help the potassium ions to leave the neuron more effectively. So let me write that down. Assists the potassium to leave the neuron. And it will also help stabilize the neuron's membrane potential. Okay, so it will really decrease the incidence of seizure because it is stabilizing the neuron's excitability. So basically, this will decrease neuronal excitability. Now let's talk about the next drug action, which is basically antagonism of the glutamate. What is this action? Well, normally, guys, in our brains, the glutamate is a very important chemical. It is a chemical that will be important in the excitation of the nerve cells, the neurons. Okay, normally it is going to be needed for the neurons to be excited, but if the neurons becomes hyper excited, then it can cause problems, right? It can lead to the seizure episode. And so with this kind of type of medication, antagonism of the glutamate, it will block the glutamate receptors. Blocks glutamate receptors. So this will now decrease the excitability of the neurons. All right, it will prevent the occurrence of the seizure because the drug is blocking those glutamate receptors. Now let's talk about the indication of the, what do you call this? The antagonism type of action. What kind of seizures will be indicated or will be treated for this perampanel, philbamate, or the topiramate? Well, these are going to be effective with the partial seizures, also the generalized type of seizure. Okay, so it can treat both types, generalized and also the partial or focal type of seizures. Antagonism of the glutamate. Now let's talk about the last one, potentiation of the GABA. What is the GABA? This is the gamma aminobutyric acid. GABA. So this is going to work as an inhibitory type of neurotransmitter. Again, this is an inhibitory type of neurotransmitter in the brain. And the anticonvulsive medications can also assist in the GABA transmission. So it will reduce the excitability of the neurons. reduce excitability of neurons by potentiating the GABA, okay? Because the GABA itself is what we refer to as an inhibitory neurotransmitter. It will decrease the super excitation of the neuron. So it has that calming effect to the neuron. Let me just write that down. Calming effect to the neuron. GABA aminobutyric acid. And so you will see here the different names of the drugs: benzodiazepines, barbiturates, gabapentin, and tiagabine. So these are known as drugs that can potentiate the effects of the gamma aminobutyric acid. It has that calming effect. It will allow the gamma aminobutyric acid to exert more action into the neuron. It will decrease excitation of the neurons. All right, so I hope that you are understanding the different drugs, different mechanisms, because this is very important, guys. If you don't know the mechanisms, you will not be able to identify the drug which could lead to this or lead to that kind of effect. It's very important, guys. Now, talking about the different medications. In general, guys, we'll talk about the mechanism of action. So again, with the different anti-epileptic medications, this is definitely intended to suppress the abnormal electrical discharges in the brain. That's the main reason. Suppress the abnormal electrical activity in the brain. So that is the main purpose why we are giving them the anticonvulsant medication. Because as we know that there is abnormal firing, right? Abnormal discharges of those impulses that can lead to excitation of the neurons and the neighboring neurons as well. And so the medication here will stop, or it will reduce the excitation. It will prevent recurrence of the seizure. Now, let's talk in general about the cautions that we need to exercise when we're giving the anticonvulsant drugs. Well, of course, if we are going to encounter a patient that may have, maybe using some anticoagulant, well, as we know, anticoagulants, we have identified them that they are going to prevent the blood clots. But when they are going to be used together with anti-epileptic medications, the anticoagulant may alter the blood levels of both medications. And that is why we are going to monitor the drug levels between the two. Again, the anticoagulants, especially Coumadin, warfarin, this can alter the blood levels of the medication. So we don't want to allow toxicity or maybe allow subtherapeutic level because of the different interactions. So we want to make sure that we are monitoring the drug levels. What else? We're going to have to consider if the person is taking the aspirin or the acetyl salicylic acid. This can also interact with the anticonvulsant medication. It can reduce the effectiveness, and it can also increase the risk of the side effects. Now, another will be the sulfonamides. So the antibiotic in the classification of sulfonamides, this can also interact with the drug action. It might elevate the drug level. It might cause toxicity of the anti-epileptic medication. Another, cimetidine, which is basically an H2 receptor blocker. This is going to also interact with the drug. It might cause elevation of the anticonvulsant medication. We also have antacids. Yeah, this can reduce the absorption. Reduce absorption of AEDs. So you got to be careful when you are administering this medication. You have to tell them that at least take the antacids maybe 2-4 hours from the schedule. It should not be taken together because it can affect the absorption of the anticonvulsant medication. So what's going to happen here if their patient is non-compliant, they're taking the antacid together with the AED? Well, they can possibly have lower drug level of those anticonvulsant medication. So not a good practice. Now, here, guys, we're going to talk about the different interventions in our pharmacotherapy. So what do we need to do? Well, not just pharmacotherapy, but actually overall. So here in our interventions, we are going to talk about monitoring the urinary output, as we know that the excretion will be done mostly by the kidneys. So we need to assess the renal function. Make sure that you have information about the kidney function, especially. Also take note about the hydration of the patient. It is very important that we are monitoring the hourly urine output. Hourly urine output. As we know that most of the drugs are excreted via the kidneys. Another intervention, we need to monitor the liver and renal function, as we know that the drugs, the anticonvulsants, are actually metabolized by the liver, excreted by the kidneys. So we need to know the liver functions, the enzymes. We need to make sure that they are not abnormally high, because if there is already an impairment in the liver function, then we're going to expect toxicity in the anticonvulsant medication. The same thing with impairment in the renal function. The patient will end up with toxicity because of what? The medication can stay a lot longer in the bloodstream in cases of renal failure. Now, another thing that we need to keep in mind is to monitor for the medication drug levels. This is very important, especially for the carbamazepine and phenytoin. And these are just two examples of the drug that have very narrow therapeutic levels. We need to keep an eye on this one because it has a very narrow window. The medication can be subtherapeutic with just missing that drug, or maybe it can be very toxic. So we need to really find out the drug levels from time to time. Now, another is to intervene by recognizing the toxicity signs. Okay, so there's so many manifestations of toxicity, especially with the anticonvulsant medication. Maybe the patient will end up comatose or maybe somnolent from taking the anticonvulsant medication, especially the phenobarbital, or let's say the Dilantin or the fosphenytoin. Oh boy, yeah, I can't remember how it was really tight working in a neuro nursing floor. We have to deal with so many seizure patients, and especially with the age factor, the elderly people, it's kind of difficult to manage the manifestations and also the drug effects. Balancing is quite difficult, really. Now, this time we will be talking about the different therapeutic ranges of the medication. So let me clear this out here. All right, so these are going to be the therapeutic levels, known medications, therapeutic levels. Okay. Yeah, Keppra is a newer drug as well. Yeah. Have you given Keppra to a patient before, Melrose? And also Vimpat. These are newer medications, but rarely coming up in the NCLEX. Those new anticonvulsant medications actually will have much lesser adverse effects to the patient. That's why they are more popular nowadays. But I've noticed that they're not really coming out in the exam, but we'll still mention them, okay? So what are the common medications with their therapeutic range. So we'll start with the popular. Vimpat is another one. Yeah, I used to give that to my mom as well. One is the carbamazepine. Carbamazepine. So what is the therapeutic level for this one? Well, this is going to be around 3 to 14 micrograms per ml. Let me rewrite that. Micrograms. 3 to 14 micrograms per ml. So the values here will be either micrograms or it could be nanograms. Please take note of the unit of measure. What about the next popular medication? Clonazepam. This is a benzodiazepine. Clonazepam, and this is going to have that GABA potentiating effect. So what is the value here? It will range from about 20 to 80 nanograms per ml. And we also have the divalproic acid or the Depakote, another popular medication. It ranges from about 50 to 100 mcg per ml. And we have number 4, we have the ethoxyzimide. Ethoxyzimide. Another tongue twister. Okay, ethoxyzimide. It's about 40 to 100 mcg per ml. And then we have the 5th one, the lorazepam. The lorazepam is used to control an active seizure. It's not usually taken as a regular anti-seizure medication because of its addictive effects. Usually it will only be used to that special occasion when the patient has the seizure episode, but not normally taken as a regular prescription. Okay, but anyhow, we still need to know about the therapeutic value, which is about 50 to 240 nanograms per ml. And then we have the old medication, the phenobarbital, which is the barbiturate. Phenobarbital, it ranges from 15 to 40 mcg per ml. And then lastly, we have the most popular, which is the phenytoin or the Dilatin. Okay, so this will range from 10 to 20 mcg per ml. So please keep an eye on the therapeutic levels. You don't have to memorize these. You have to just kind of familiarize with the ranges. And look into the ranges here. They're quite similar, like let's say 10 to 20, 15 to 40. We have the divalproic, which kind of runs a little bit higher, 50 to 100. But the unit of measure here is a microgram, okay? And so, again, the clonazepam, or let's say the lorazepam, is intended only during an active seizure. We can give this as an IV form when the patient is seizing actively. Of course, you're not going to give anything by mouth in a patient that is seizing. No, we're not going to do that. They're not safe to take anything by mouth. So again, these are just the drug levels for your reference to see if our patient is still safe to take the medication. All right, so with the recognition of the medication toxicity, what are the common manifestations of our patient, especially when they have toxic effects of the medication? So let's talk about the central nervous system effects. What do you think the patient will end up when they're gonna take these anticonvulsant medication? Well, their mentation, their alertness will be reduced. Decreased alertness. They're going to be confused and also sedated. These are expected findings, right? But if the patient will no longer respond to you, Once you call them or once you tap their shoulder, they're not responding. Something is not right with your patient. Maybe they're getting way too much of the drug. Maybe the drug is too toxic to this patient. So we really need to respond to the situation wherein the patient is no longer responsive. Maybe they're now comatose. Yeah, we can think of so many problems that may set into this patient. They might not be able to manage their secretions. Their airway is going to be a huge issue. They probably end up with a buildup of carbonic acid. They might be going to complicate into a respiratory acidosis, or they might need some intubation and mechanical ventilation if our patient is severely depressed in their CNS function. So you gotta intervene with that. Now, another common effect in the anticonvulsant is the ataxia, abnormal gait. The reason that I am discussing all these side effects, because these are things that the NCLEX will be asking you. Risk reduction. Yeah. Ataxia, which is basically the impairment in their gait. Our patient here will be uncoordinated. They will not be able to maintain a steady gait. They are going to be fall risk. Okay? They will not be able to maintain their own safety. They probably would be climbing out of bed several times in your shift. Oh, that would be fun. You're going to activate the bed alarm. Maybe you're going to ask for a sitter to stay with the patient this time in order to keep them safe. Other problems here, let me erase this section. Another effect of the anticonvulsant medications are the following. Not just CNS, it can also affect the gastrointestinal system. So, what do you think are those effects you need to watch for? Okay. Well, for the GI, you probably would just ignore this one, nausea and vomiting, but no, we are not gonna ignore this. The patient will have much more persistent vomiting or nausea. They probably end up not taking any more food because they just want to not nauseous anymore. They might be refusing their meals. This can lead to malnutrition as well. So we need to treat this as well. Maybe the patient will require anti-emetic medications, or our patient might need modification in their nutrition. Maybe they are going to require frequent small feedings as well. Okay. Now, visual disturbances can also occur as part of the CNS effects. So again, our role here, guys, is to report any symptoms of toxicity to the healthcare provider. And depending on the severity and the adjustment of the medication will be necessary to avoid the complication. Okay, so our role here is to notify the healthcare provider after we found out that our patient have developed toxic effects of AAD. That is our role. You will be asked this in the NCLEX regarding what signs of toxicity you should report to this patient if they take this anticonvulsant medication. All right, let's move forward, guys, regarding our nursing role. Well, we definitely need to get a thorough assessment of our patient. We're going to have to gather the history of the patient. Maybe they have extensive seizure history. How many episodes they usually will have in a month. Do they have any warning signs, prodromal symptoms, maybe the nature of the seizure itself? We need to identify what kind of behavior they have during the seizure, and also the post-ictal period. What is this post-ictal period? Well, this is the time when they are going to recover. And during the post-ictal period, especially like after a grand mal seizure, the patient will be sleeping. They will be fatigued for a duration maybe of 2 to 4 hours. And around that time, this is very critical because they are not going to be able to protect their airway. That is a main issue here. Airway patency. So we want to make sure about addressing their airway, make sure that their oxygenation is fine, their vital signs are okay, and we also want to prevent any more complications, right? Especially if their oxygenation is getting low. We need to deal with that. If there's a need for us to administer oxygen, go ahead and give them some oxygen to counteract the effects of hypoxemia. Now, another thing that we need to do is to get detailed description of their activity, the seizure activity. Okay, we need to see if they have both if they have both tonic-clonic, or maybe they're just having the blank stare, or let's say they have the clonic only, or maybe the tonic type. So we really need to obtain more information. And the same thing with the psychosocial impact. We need to investigate about its effect to the patient. We need to explore their emotional and social effects after the seizure, because this is going to be debilitating. It will limit their daily activities. Now, substance abuse history. This is also important, guys, because as we know that part of one of the contributory factors in the seizure is basically the what? The use of those substances like the cocaine, the alcohol, what else? Maybe medications that they are taking, the benzodiazepines. So if they will suddenly stop taking these substances or medications, they're going to end up with withdrawals. Okay, so think about the episodes of withdrawals here. Withdrawal from substances. And I'm talking about the medication, which is probably a prescribed drug, and maybe they cannot afford to take that drug anymore. They will just, yeah, I can't buy any more of this drug. I'll just stop taking it. Prescription medications, alcohol. Okay, so these are known substances that might cause the seizure to occur once they stop immediately or stop abruptly taking these. Now, another is the medication adherence. This is very important because if they are not taking religiously the dosing schedule, again, this can cause subtherapeutic levels of the medication. It's no longer helpful to prevent the seizure episodes. Now, we will be talking about the nursing interventions that you should be doing when the patient has an active episode of seizure. Okay, so what are you going to do here? Well, first and foremost, prevent injury. This is going to be your immediate priority in a patient in a seizure episode. When the seizure starts to occur, prevention of injury is a must. We want to keep a safe environment of our patient. Maintain safety. That is the top priority in our patient. What are we going to do here to maintain safety? We're going to what? Apply, or before the seizure can happen. Let's say, for example, the patient already is known to have seizures in the past. And once they get admitted to the ED, or let's say the nursing unit, you got to be prepared in setting up the patient's bed. You need to apply those padded rails. Okay? Pad the side rails. That is very important. Pad the side rails. These are basic nursing actions that are often asked in the NCLEX. Pad the rails, lower the bed height. Okay. We're also going to remove clutter to prevent injury to our patient. Okay. Now, the reason that we're going to lower the height of the bed in order to prevent falls. Okay. We don't want them ending up with a fall because the height of the bed was adjusted way too high. Maybe you did some procedure and forgot to put it down. You have to make sure that this is going to be provided to the patient. And we have a floor mat from Melrose. Yeah, of course, we're going to have to Also provide floor mat or maybe those non-skid socks. Have you seen those? For those inpatients wearing those non-skid socks, actually they have those sticky material underneath the pair of socks. This will prevent slipping. Okay, so if in case your patient that is ambulatory with a seizure, of course they are not going to be prevented in walking if they're still able to do it, but you really need to keep an eye on these patients. So the non-skid socks or let's say floor mat that will prevent slipping will be afforded to our patient as well. Okay, now another tip for you. You should not restrain the patient during the seizure episode. Do not apply restraint during the seizure. Never do that. It can add more additional harm to our patient. So do not. Keep the rails padded. Watch the duration of the seizure. Make sure that the patient is not going to bump into a very hard surface, and make sure that their head is also protected with a cushiony material. Okay. Now, another intervention here in promoting or preventing injury is to position the patient on their side. Side lying position. All right. In order to prevent aspiration. Okay. Again, head protection. That is another one. Make sure that the head is padded with soft pillows. Okay. Now, if in case you are walking your patient in the hallway, a patient that is known to have a seizure, and of course, we're going to allow them to have some form of ambulation. And let's say, for example, all of a sudden your patient end up seizing and you are walking with a patient. So what are you going to do in that scenario? So when the patient starts to seize while ambulating in the hallway or maybe in the room, what you're going to do here is to ease the patient down to the floor. That is your action. Ambulating, and then there is a seizure. So what are you going to do here? You're going to have to ease the patient to the floor. This is a common scenario. Once you do that, you're going to have to protect their head against the hard surface, especially the floor. Protect the head. You can use your hand probably around this time to pad the, oops, I erase it. You're going to have to pad the head momentarily using your hand to protect the head from bumping into the floor. So ease patient down on the floor, and then head protection will follow. And then you can call for help. Get somebody to get a piece of pillow in order to pad the head against the floor. And then you're going to have to proceed with the same sequence, making sure that the patient is placed in a side-lying position in order to drain the saliva during the seizure episode. And again, we're going to have to check for the patient's oxygenation. We're going to have to carefully assess their airway as well, if there is a need for us to suction their oral cavity because of the salivation. We need to do that as well to maintain an open airway. Okay. Now, we are not going to leave the patient around this time. If you are the nurse with the patient seizing, do not leave the patient. You're going to call for help. Maybe if you are in the patient's room, you can use the call light button, or you can use the bedroom telephone to call for help. Do that and then ask for assistance from the team. Now, for example, if the patient will start to have cyanosis, what you're going to do here is to check for airway. This is very important. Airway patency is going to be very critical around this time. You have to probably after putting them in a sideline position, it will help drain the secretions, right? But if there is still excessive secretions, and once the seizure episode has stopped, you're going to apply suction to get rid of those excess salivary secretions. Now, there could be suctioning that will occur here. Suction oral cavity. And then if the patient maybe doesn't have an IV, which can potentially happen, maybe the IV has now been infiltrated while they were maybe it's no longer working, then we're going to have to establish IV line as well. IV line establishment in order that we can give those necessary anticonvulsant medications. Maybe lorazepam, maybe Dilatin IV. We need to do that. And if there's also a need for us to add more anticonvulsants as ordered, then we're going to have to deliver that as well, ASAP. Now, let us talk about, oh, here we go. Let me erase this. I thought I had everything. We're going to avoid restraints. Do not insert anything in their mouth. No suctioning during the active seizure, not even. No suctioning during the active seizure. You're going to only do that once the seizure has stopped. Okay? We're going to have to position them to the side, protect the head, and we're going to have to maintain the airway in order to allow adequate cerebral tissue perfusion. We're going to have to administer oxygen to combat hypoxemia. We're going to have to establish IV as needed. If the IV is no longer patent, which happens usually during an immediate event, don't you hate that whenever you're going to need to administer a drug and all of a sudden the IV is not working or the patient screams in pain? Yeah, it happens. And also, we're going to have to administer additional anticonvulsant medications as ordered. And if in case, guys, if you're going to encounter this much more of a worse form of a seizure, which is the status epilepticus, this is a very serious type of seizure wherein the person will experience a more of a continuous, or there will be repetitive seizures. They are not regaining consciousness between the episodes. So basically, they're just going to go on and on having the seizure. You've been giving them the anticonvulsant medications, but still, the patient still will experience continued seizure episodes. Continuous seizure. Or maybe recurrence of seizure or repetitive seizures. And they are not regaining consciousness. Not regaining consciousness. And now our worry here is the blood supply to the brain, right? It is a medical emergency. It has high mortality rate. So we definitely need to intervene in this patient with status epilepticus. It is a medical emergency. It has high mortality rate and it can cause brain damage. Call 911. If you are in the home setting, or let's say if you're the home health nurse, then yes, you can call the 911. Or let's say in an assisted living kind of setup. Also with the nursing home, those kind of facilities don't have the ability to really control this kind of seizure. Okay, so they need to call 911 for that. However, if the patient is in the acute care setting, inpatient, right? So we are going to need extra help around this time. We're going to call for the rapid response if the patient is not responding to the treatment. Okay, because this can cause, again, brain damage. The mortality rate is high in this patient because of the anoxia. Now, what do you think are the causes of the epilepticus, status epilepticus? There are so many. One of those causes are the following. It could be caused by just a simple fever. Fever could be metabolic imbalances. Could be the low sodium level, right? Maybe alcohol withdrawal. That is another one. Or maybe emotional stress, environmental stress, stresses, emotional stress, environmental stress, and in some cases, sleep deprivation. Aren't you worried about that? Who's not sleep deprived among you? All right, sleep deprivation can also give Advent IM. Yeah, that's going to be one of those. But again, you're not going to expect cessation of the, what do you call this, the seizure activity just one with just one dose. This patient will require with ongoing treatment to stop the convulsions. Yeah, we'll talk more about that. Now, what are we going to do when the patient goes into status epilepticus? Again, we're going to go through with the same sequence of nursing care, pad the rails if the patient is in the inpatient room, lower the bed, avoiding restraints, don't insert anything in their mouth. Those are the important stuff as well. Position to the side, protecting the head, maintaining the airway, administering O2. We need to establish IV. If there's none, we need to administer the anticonvulsant, maybe additional doses as well. But here, we're gonna possibly need to intubate this patient. We're probably gonna have to place them in a mechanical ventilator because they will not be able to manage their airway. Okay, so mechanical ventilation intubation is expected here. If it's prolonged, if it's continuous, yeah, the oxygenation is an issue here. Okay, oxygenation, your airway, these are the main issues in this patient with the status epilepticus. A, B, C. The airway, the breathing, and the circulation of the patient is highly compromised in this condition. So, what else are you going to expect to be done to this patient? Of course, aside from placing them in intubation and mechanical ventilation, we're going to have to monitor their anticonvulsant drug levels as well. Okay, so monitoring of the drug levels, that is another one, sorry. Drug level monitoring. Yeah, Anita is correct. Medical induced coma, we need to do that as well in order to safely manage this patient. Our medications, the anticonvulsant medications I'm referring to, should be monitored in order that we can achieve the therapeutic levels. Okay, so those are the main, what do you call this? Main actions that we should be doing into this patient. All right. What else? O2. Of course, mechanical ventilation. Before we do the mechanical ventilation, of course, O2 supplement will also be needed for this patient. If we notice that our patient is hypoxemic, we need to make sure that they're getting enough oxygen to the brain. That's another one. Put patient on seizure precautions. That's what we are actually doing. These are all steps in seizure precautions. Okay. One of those will be oral suctioning. Okay. Post-seizure. So these are what we call as seizure precautions: padding the rails, lowering the head, the bed rather, this one, positioning to the side, the use of oral suctioning after the seizure has completed. What else? Yeah, those are the most important things: padding the rails, lowering the bed, positioning them to the side, application of oral suctioning, and also O2 supplementation. There are so much more, guys, in the list. Okay, So these are the interventions that you should expect doing to your patient. Okay, dokie, let's move on with education. Our education here is geared towards more of identifying the triggers, so they will know for sure what to avoid. Let's say missing meals or maybe lack of sleep. We need to make sure that they're able to manage this at home, or maybe teach the caregiver if they live with a caregiver at home. We also need to also emphasize the importance of their compliance to the medication regimen, so that they will not miss any of the medications. We're going to advise them against the use of alcohol. What else? We're going to have to teach them, make sure that they wear that medic alert for those highly active patients that have seizure history. They need to wear the medic alert in order to help the standby people to identify that they have this kind of disorder, and also balancing of their lifestyle. It's very important in order to make sure they are not gonna be prone to developing the seizure episodes. They need to have like regular exercises, and also nutrition, and also mental stimulation as well. Now, they probably would need some surgical options if in case they're not responding to the regular or the routine medical interventions. So this is going to be helpful for these patients. So recalling about those different surgical procedures, make sure that they have that information as well, so they can inquire that to their medical provider. All right, let's start with our Q&A, guys. It's been quite a long wait today. And so let's start with question number 1. A male patient who might have cerebral edema has a serum sodium level of 116 milliequivalents per liter and a declining level of consciousness. He also complains of a headache. What should the nurse do first among the following prescribed interventions? Is it A, administer IV 5% hypertonic solution saline? B, draw blood for arterial blood gases? C, send the patient for a computed tomography CT scan? D, administer 650 milligrams of oral acetaminophen Tylenol? What do you think would be your intervention here? So it said, what should the nurse do first among the following prescribed interventions? Is it administering IV 5% hypertonic saline? Or B, draw blood for ABGs? C, send the patient for a CT scan? D, administer 650 milligrams of oral acetaminophen? What's your answer? Okay, let me proceed with eliminating the answer. We have Anita answering letter A. Okay, we are also seeing from Graciously, James, Vinasidaran, Adiola, and Masabiata, Jet, Catherine. Good. All right, let's start eliminating those unnecessary options. Let's start with letter D. Administer 650 milligrams of oral acetaminophen. Okay. What do you think about this intervention? It seems okay, right? We are administering Tylenol to address the headache. Yeah, it can address the headache. Only addresses the headache. Do you think of anything else that might be beneficial for the Tylenol? Okay, nothing else, right? It's just going to remove the headache. You're treating the patient symptomatically, just the headache. But take a look, the severity of the sodium, 116. Okay, now let's take a look on letter B. We're going to eliminate letter D right away. What about letter B? What is in draw blood for arterial blood gases? Do you think that this is going to be helpful for this patient with hyponatremia? Yes, it can be a good action to monitor the patient's acid-base balance, but it will not address the hyponatremia. Does not address hyponatremia. It doesn't. It will only monitor the imbalances between the pH, the bicarbonate, the PaCO2, or maybe the PaO2. Now let's take a look on to letter C. Send the patient for a computed tomography scan. I know this is also a good diagnostic test, right? And this is going to identify maybe structural problems within the brain or maybe cerebral edema. Can detect structural issues in the brain. Such as edema. Okay? But will it treat the patient's hyponatremia? No, it doesn't. We need to address the severe hyponatremia of our patient. Does not address a critical sodium level. It doesn't. We need to do this first. Hypertonic saline solution. It is 5%. This is going to be our drug of choice. Guys, this is a priority because we need to start stabilizing the patient's sodium level. Hypertonic saline solution. Why are we going to give them hypertonic saline solution? Well, the reason is that the patient has cerebral edema. Okay? What are we going to do? Or what is the significance of the hypertonic saline solution to the cerebral edema? So let me try to simplify things here. Okay? So let me draw a brain. Okay, let me just put a circle here. Supposedly this is like the brain tissue. Okay, so our brain cells are edematous, right? They are huge. They are swollen. Okay, and in administering the sodium hypertonic solution, what it can do is actually draw the fluids coming from the insides of the cells. It will draw the fluids from the brain cells. It will attract. Okay? So what's going to happen to the fluids? It will shift from the brain cells into the vascular compartment. Intravascular compartment. So it will shift the fluids coming from the brain cells into the intravascular compartment. That is the reason why a hypertonic solution is going to be effective. But the question says, who might have cerebral edema? Well, it can be anyone in so many disorders. There are so many people that may have cerebral edema. It could be a patient that may have a syndrome of inappropriate antidiuretic hormone, or it could be a patient that may have a head trauma with an increased ICP. Or it could be a patient that may have an evolving stroke. So these are patients that are known to have or to develop cerebral edema. Okay? Or maybe those patients that have been getting the hypotonic fluids, maybe getting the, half normal saline, and we are not monitoring their, electrolyte levels. Yes, they can experience the cerebral edema if we are not monitoring our fluids, okay, especially the hypotonic fluids. Now, again, those are the SIADH patients, patients who might have head trauma with increasing ICP, our patients that may have evolving stroke. What else that you can think of? Maybe those patients that may have liver failure, okay? Or those patients that may have renal failure. Remember those? Especially if there is high BUN levels. And when they're going to do that dialysis in a very rapid fashion, there is immediate extraction of those byproducts in their body. This can cause cerebral edema. All right. So we are going to treat this patient with hypertonic solution. Okay. Now, guys, you have to observe and strictly observe the protocol in replacing the sodium of this patient. What are you going to do here is to observe, let me erase this. You're going to have to abide with the policy, the institutional policy regarding the replacement of the sodium, especially if you're administering hypertonic saline solution. This is going to be administered only in a central line, okay? The IV fluid itself is very salty, hypertonic. It can cause extravasation of the regular peripheral vein, okay? So it should be administered in a central line. There will be going to be administration of, let's see, serial sodium level monitoring. It should be checked frequently, maybe every 4 to 6 hours, to see if there is rapid replacement. Because if we are going to rapidly replace the sodium level, it can lead to this problem we call as ODS, osmotic demyelination syndrome. Have you heard of this one? ODS. Wherein you're only allowed to increase the patient's sodium level, let's say 8 milliequivalents per liter in about maybe less than 12 hours. You will not be replacing this hyponatremia way too fast because it can cause ODS. This is what we call as osmotic demyelination syndrome. And the patient that will complicate into this disorder, they're going to end up with so many issues. Let me write them down. They're going to end up with quadriplegia, dysphagia, and also confusion. This will cause the peeling of the myelin and their central nervous system because of the rapid replacement of the sodium. We don't want that. It has to be administered in a way that we are monitoring the levels, that we are not overdoing or we are not rapidly replacing the patient's sodium fast. We don't want that. Okay? So the reason that we are going to check the sodium levels frequently is to prevent rapid correction of the sodium. Okay? And the complication is what we call as ODS. This is a complication that can become irreversible. They will become quadriplegic. They will have some issues with their swallowing, and they will get confused. And there's so much more manifestations, but I'm just highlighting the very important manifestations here. Okay, don't forget about ODS. This is the result of a rapid correction of their sodium level. Okay, so take note about the central line. This is not supposed to be administered in a regular peripheral IV access device. It has to be delivered in a central line because of the hypertonicity of the solution. It can cause extravasation and phlebitis. All right, let's talk about number 2 question. While transporting a patient on a stretcher to radiology, The patient starts having a tonic-clonic seizure. What should the nurse do? Is it A, insert an oral airway during the seizure? B, restrain the patient's arms and legs? C, time, observe, and record details of the seizure and post-ictal state? And D, avoid touching the patient. The question is, while transporting a patient on a stretcher to radiology, the patient starts having tonic-clonic seizure. What should the nurse do? A, insert an oral airway during the seizure. B, restrain the patient's arms and legs. C, time, observe, and record details of the seizure and post-ictal state. And D, avoid touching the patient. Okay, I think we are safe. We're going to choose what? Letter C. Time, observe, and record the details of the seizure and post-ictal state. And the reason for that is to assess, accurately document the seizure's duration and its characteristics, because if it's going to be prolonged, this will cause brain anoxia. We need to intervene right away if the patient's seizure episode is much more prolonged. We need to address that right away. Okay? We need to intervene. And also with the timing of the duration, this is going to be helpful in documenting and making sure the healthcare team is aware, because there is going to be a potential that this pattern, a longer type of seizure activity, might recur in this patient. And that is why it is very important to record the length, the duration, and also the details, the kind of seizure activity that they have. All right. If we are answering, okay, this is correct. Answer is letter C. For letter A, insert an oral airway during a seizure. We're not supposed to put anything in their mouth because it might cause injury into the patient. It might cause dislodgement in one of the diseased tooth or teeth. You're not going to do that. No way, Jose. No airway placement during the seizure. You can always put them on their side and do the suctioning when the seizure episode has completed. Okay? Not letter A. Letter B. Restrain the patient's arms and legs. Like I've said earlier, there should be no application of restraint because this can lead to more injuries. What you're going to need to do here is to protect the patient from any clutter. You have to pad the railings. If the patient is in their room, in their bed, make sure the rails are already pre-padded and move those objects away from them if they are probably eased down into the floor. So we're not going to do this. Letter D, avoid touching the patient. Well, the excessive stimulation of the patient should be avoided around this time. We need to just position the patient appropriately in order to prevent injury, not really avoiding entirely. We can reposition them as needed, but not avoid touching. It's kind of like so extreme. So again, our focus here is to provide safety of our patient, make sure that we are documenting properly the length of the seizure episode. This is going to be needed in the future treatment of the patient. Let's tackle number 3. A university professor diagnosed with epilepsy after a generalized tonic-clonic seizure expresses a concern about continuing to teach, fearing seizures at work. How should the nurse respond? A, you might benefit from psychological counseling. B, epilepsy is usually well controlled with medications. C, you should contact the Epilepsy Foundation for support. And D, the Department of Vocational Rehabilitation can help with job retraining. What is your choice here? Again, the patient is diagnosed with epilepsy after a generalized tonic-clonic seizure. So worries about not able to teach because of a possible occurrence of seizure at work. So how are you going to therapeutically respond to this patient? Are you going to tell her about letter A, or is it B, or C, or D? Okay. What you can do here, guys, is to basically answer the question, or let's say deal with the concern objectively, but not giving false reassurance. But what you can do here is to give them that accurate information when you are faced with this kind of scenario. Okay, let's take a look here on letter D. The Department of Vocational Rehab can help you with job hunting. Well, the job hunting, basically, the department will not help really with the concern, because it is stated that the patient is concerned about what? The possibility of seizures happening at work. It's not gonna prevent that, okay? It's just advising them to get another job. So not really gonna help. Disregard this one. Remove letter D. This is going to be applicable for a much long-term solution, but it doesn't address the current concern of the patient, okay? It doesn't address the current concern about her ability to teach. It's like a dismissing statement. Let's talk about letter C. You should contact the Epilepsy Foundation for support. Again, this is the same with letter D. It is, yeah, you're giving them an idea that they can get additional support, but the immediate concern here is needed, all right? This is not addressing the main concern, main worry of our patient, okay? You're just kind of like prolonging their concern. I'm not really getting a good answer from this nurse. Should I get another nurse? No. We're eliminating this one. What about letter B? Epilepsy is usually well controlled with medication. Is that true? Is it true? Epilepsy is well controlled with medication? Well, so far, as based on the evidence-based practice, the anticonvulsant medications, those drugs can safely manage the patient's epilepsy effectively. And this is going to really allay some anxiety to the patient. It directly addresses their fear, okay, without giving them false reassurance, okay? Epilepsy is usually well controlled with medications. The challenge here, though, is it might take some time before the medical provider will be able to really prescribe that particular drug that would best fit for this patient. So it might involve maybe modification of the prescription up until the patient would have less and less seizure activity, okay? And it's not easy switching from one medication to the next. It will require time, frequent monitoring, and also checking for the adverse reactions, as we know that there are known adverse drug reactions. And again, this is going to be our most truthful answer to the patient. This is not giving false reassurance that their manifestations can be controlled with the anti-epileptic drugs. Letter A, you might benefit from psychological counseling. Yeah, it's just like, yeah, I'm just blowing you off right now. I can't really address this. No, you're not supposed to give this kind of statement. Directly, it's not addressing the concern of our patient, all right? Even though counseling is beneficial, but in order for us to address the main statement, we're going to have to use letter B this time, okay? We need to address the patient's concern right there and then. So our correct answer here is letter B. Let's proceed with number 4. Hello, everyone. Hello, Eileen. Number 4, a patient who has been on phenytoin for 2 years needs to be evaluated for adverse effects. What should the nurse assess? Is it A, oral mucosa, B, lung sounds, C, bowel sounds, D, pupil reaction to light? A very easy question. A patient who has been on phenytoin for 2 years need to be evaluated for adverse effect. What should the nurse assess? Letter A from Mary. Is it lung sounds? Is it bowel sounds? Is it pupil reaction to the light? So this is now chronic use of the dilatant, phenytoin. Okay. So let's eliminate letter D. Let's try to do that first. What's in letter D? Pupil reaction to light. What do you think about the dilantin effect to the pupils? Will it influence the reaction, the pupil's reaction to the light? No, it does not have any influence to the pupils. Dilantin, no known effects to pupillary response. It doesn't. So you're going to eliminate that one. What about letter B or letter C? Bowel sounds. Will it influence the bowel sounds? Well, guys, as we know that dilantin can also lead to GI effects, but mentioning here, let me just put here, GI side effects. It can cause some nausea, constipation, okay? These are side effects. However, they are not adverse effects. So we're gonna eliminate bowel sounds this time. They are side effects, but not adverse effects. So we are going to continue monitoring our patient with the constipation, nausea, and we're gonna advise them to take in a bit more of the fiber in their diet in order to prevent the side effect. What about letter B, lung sounds? What do you think about the lung sounds? Will it influence the respiratory system? Well, it's not known to really affect the respiratory system, even though it can do some complications, but not into the respiratory system. It's not known. But here, oral mucosa basically can capture the gingival hyperplasia. This is a common adverse effect of the dilantin. So it is very important for us to educate our patient before initiating the therapy that they need to inspect their mouth and also to use oral care judiciously. Make sure that they're going to massage their gums. Also use the dental floss to prevent gingival hyperplasia. This is the correct answer. Okay, is letter A. Again, oral mucosa checking is going to be helpful for this patient. Now, let's talk about the other side effects of the dilantin, because this is a very common drug appearing in the NCLEX. Dilantin side effects. Again, first common is actually adverse effect. Changing that. Again, what we're going to do with that is to check for gingival hyperplasia. And dental hygiene, dental care is very important, guys. Another is the nystagmus. It is an involuntary eye movement. So here we need to monitor the patient for any changes in their vision. Eye exams would be very helpful. Okay, nystagmus. Eye exams will be recommended. There's also diplopia, double vision. That's another adverse effect. Same thing with the ataxia, loss of coordination. So our patient will be prone to falling this time, especially maybe they are using those heavy machineries or let's say driving. Yeah, they cannot drive anymore, guys, especially if they have a diagnosis of seizure. This is one thing. I don't know who's coming here in the US here, but I've dealt with so many patients with seizure. This is a reportable event, okay? Especially in California. This is a reportable event. The medical provider will report this to the Department of Motor Vehicles, okay? There will be certification, a documentation coming from the medical provider that this patient has a diagnosis of seizure, okay? This patient will not be able to drive again unless they are cleared from being safe, driving a car in anywhere. They cannot drive anymore up until they are cleared to do so. Again, this is a reportable event to the Department of Motor Vehicles, okay? DMV. Yeah, they cannot drive anymore. Well, this one, ataxia, loss of coordination, they're not supposed to be dealing with those activities that will require attention, alertness. They're not going to be able to they're not going to be allowed to drive anymore. Like I've said, no handling of machinery that might cause injury to them, not anymore. All right. Another side effect or adverse reaction would be the, I'll just say side effect right here because this is very manageable, the dizziness and the drowsiness. So again, they need to be alert in managing some kind of machinery, so they're not supposed to be doing that anymore if they encounter these side effects. Oh, another one, adverse effect, skin rash. If this comes out in the test about skin rash after taking Dilantin, this is an adverse event which we call as the Stevens-Johnson syndrome. Stevens-Johnson syndrome. So this is going to be a serious reaction to the drug. They're going to end up with that massive peeling of their skin, okay? So it will cause that massive rash and will end up with a necrolysis. So their skin will peel, just like being in a severe sunburn. This would require immediate halt. This should be discontinued right away if the rash develops. It will require immediate medical attention. So skin rash, the Stevens-Johnson syndrome, will be reported right away to the medical provider, and then this will call for discontinuation of the drug and needs replacement with another anticonvulsant drug. Okay, it will require another anticonvulsant medication. Now, another adverse effect that is known is hirsutism, overgrowth of hair, especially in women. There's going to be thickening or coarsening of the facial hair. This is going to really bother especially women that are so feminine, right? Hirsutism is going to be a big issue. What else? I think that would be the most important stuff for the adverse effect. Gingival hyperplasia, nystagmus, diplopia, ataxia, the skin rash, and hirsutism. Now, what are we going to need to do, especially if the patient will be getting the Dilantin? It will require regular monitoring of their blood, therapeutic level of the phenytoin in order that we can capture if it's subtherapeutic or maybe toxic, and this might require adjustment of the medication dose. Now, take note, guys, this is a drug that is known to cause birth defect. Not indicated for the patient that is pregnant. It can lead to the birth defects. So this is supposed to be not taken by this person. They need another drug for this, okay? Or we will be teaching the patient to use other means of birth control, okay? Birth control will be highlighted because the medication itself can make the birth control medication less effective. So birth control alternatives must be investigated here. So find out what is best for this childbearing woman in order to prevent pregnancy, especially if they are in the childbearing age. All right, let's talk about, I have not completed yet. Other than that, the drug can also cause liver impairment, liver function impairment. That's another one. So we have to monitor the patient's LFTs, the AST. So basically, we will include here our liver malfunction as adverse effect. Okay. AST, ALT checking is very important here. All right, let's move on to the next question. A patient reports numbness and tingling in the left arm before a seizure. What type of seizure does the nurse determine this is consistent with? Is it A, focal, B, atonic, C, absence, D, myoclonic? Very easy, subjective, objective question rather. What do you think about that question? A patient reports numbness and tingling in the left arm before a seizure. What type of seizure does the nurse determine this is consistent with? Is it A, focal, atonic, absence, or D, myoclonic? Masiabata. Okay, I'm sorry, I mispronounced your name. Letter A. All right, let's try to eliminate the answers. What about letter D? What is myoclonic? Remember that the myoclonic seizure, it's going to be sudden. It is characterized as brief, jerky twitches of the muscle or a group of muscles. Yeah. So the myoclonic doesn't really fit to the description in the scenario. We're eliminating that one. What about letter C? Absence type of seizure. What do you think about letter C? We know that the absence is the pitimal type of seizure, right? It is very brief. It's sudden. The patient will end up with a sudden lapse of consciousness. And this is going to involve the blank stare, unresponsive. There's also probably blinking or lip smacking around this time. Okay. So if you are going to answer this letter C, it is wrong because the absence or the pitimal type of seizure doesn't have a precursor. No precursor, no numbness, no tingling. No precursor before the episode. Okay. All right. They're only going to have the lip smacking, the blinking during the seizure, but no numbness, no tingling before the episode. So what is that? This is going to be the focal type of seizure. Okay. That is the focal type. If you're answering atonic, this is basically what we termed as the drop attacks. What does that mean? It simply means that the patient will have a sudden loss of muscle tone. So they're going to end up collapsing or dropping on the floor abruptly. They do not manifest any precursor. So no precursor as well. No precursor. All right, so our correct answer here is only letter A, focal type of seizure. Okay, remember about the different types of generalized seizure. We have the myoclonic, absence, the atonic, the clonic only, the tonic, and the general or the grand mal seizure. The focal type is totally of a different family. All right, let's move on to the next question, number 6. A patient in the ED is experiencing continuous tonic-clonic seizures. Which prescribed intervention should the nurse implement first? Is it A, administer phenytoin dilatin 100 milligrams IV, B, monitor the patient's level of consciousness, C, give lorazepam Ativan 4 milligrams IV, and D, obtain a computed tomography scan? So in the ED, the patient is experiencing tonic-clonic seizures. And here you are tasked to intervene, which should be done to this patient with a tonic-clonic seizure. Are you going to implement A, B, C, or D? What do you think can provide immediate and critical care to this patient? What would be that medication that can immediately address the tonic-clonic seizure? So that is what we're going to look for here in this situation. All right, let's start to clear our options. Let's start with letter A, administer phenytoin dilatin. I know this is an anticonvulsant medication, right? It is an AED, anti-epileptic medication. It can treat the generalized type of seizure. It can also treat the focal partial seizure, but onset is slower. It will not act on controlling the immediate tonic-clonic seizure. We're not gonna select this as our primary treatment. Okay, it will be given as soon as the patient receives what? Letter C. This is our answer. The benzodiazepine Ativan lorazepam is going to be the drug of choice to stop the tonic-clonic seizure. Do you remember the drug effect of the lorazepam? Remember that it is what? A neurotransmitter that actually the lorazepam will enhance the effect of GABA. And the GABA has that inhibitory effect. It will terminate the seizure activity by inhibiting neurotransmission. Inhibits neurotransmission, decreases the excitability of the neurons. Okay, so it will act really fast. It can act rapidly to control the seizures, but not the phenytoin. Let's take a look on letter B. Monitor the patient's level of consciousness. I know it's very important that we're going to monitor, right? But will the monitoring address the seizure activity? It does not. We're going to do the monitoring. The reason for that is because we have to check the level of, or we'll check the overall neurological status of our patient. From time to time, we want to make sure that they are safe as far as managing their oral secretions. We gotta have to check if they are now starting to wake up. They're known to have the post-ictal phase, but yeah, we need to keep an eye on this patient, especially with their LOC, because if they're not really responsive, even with a painful stimuli, that's not a good sign. They probably would become comatose from the complication. So this will be done after administering the lorazepam. Okay. Number 7, a patient has a new prescription for Dilantin. Which finding should prompt the nurse to consult with the healthcare provider before administering the medications? Is it A, the patient has tonic-clonic seizures? B, the client experiences an aura before seizures? C, the patient has minor elevations in liver function tests? And D, the patient's most recent blood pressure is 158/90 mmHg. So this situation is describing a patient with a new prescription of Dilantin. So which of the following options that you should report to the healthcare provider before administering the drug? Before giving the drug, you should have that baseline information about LFTs. Remember, it can alter the liver function. Make sure that there is periodic checks on the liver enzymes ALT, AST. Because if there is already a pre-existing liver impairment, well, do you know that the liver is the primary organ that will metabolize the drug? It is the only organ that can process the Dilantin effectively. If it's not able to do its job, then the patient will end up with toxicity. Okay? Increased AST can result to Dilantin toxicity. All right? What about letter A? The patient has tonic-clonic seizures. Would that be a requirement before we're going to administer the Dilantin? No. The phenytoin is supposed to address the tonic-clonic seizure. It is going to stabilize the neurons as well. Okay? What about letter B? The patient experiences an aura before seizure. We know that the aura is the warning sign before the seizure episode occurs. But the use of the Dilantin can be done. It can be given. Either the patient doesn't have an aura, or maybe if they have an aura, it doesn't really matter. So there's no relevance into this option. Now, letter D, the patient's most recent blood pressure is 158/90. It doesn't really interfere with the blood pressure. Is not going to, the high blood pressure will not really play a factor in the administration of the Dilantin, because the medication itself does not significantly affect the blood pressure. Okay, so it's known to be safe for those patients with hypertension. Okay, so that's it. Our answer is letter C. Let's talk about number 8. A patient treated for status epilepticus in the ED is being transferred to a medical unit. Which equipment should be available in the patient's room? Select all that apply. Is it A, side rail pads, B, tongue blade, C, oxygen mask, D, suction tubing, E, urinary cath, F, nasogastric tube? What do you think would be necessary in the patient's room? Will that be side rails, tongue blade, oxygen mask, suction tubing, urinary cath, nasogastric tube? This is a select all that apply. Graciously answered A, C, D. That's it. That's side rail pads, oxygen mask, and suction tubing. Okay. Very good. I'm seeing Mary as well, and Adiola. Wonderful. Okay. Now let's eliminate E and F, urinary catheter and nasogastric tube. They're not going to be required in the care of the patient. Urinary catheter, there's no specific indication for that for this patient. However, it can only be needed if the patient will have issues with urinary retention. indicated only if there is urinary retention. Okay, but it's not going to be used routinely after the patient has a seizure. Okay, we're only going to put anything invasive into the patient's body if they need it. If there's no reason, then we're not going to put any urinary catheter. Okay, what about nasogastric tube? It's not going to be required unless there is a specific order or specific indication, maybe gastric decompression, or maybe if they're going to have issues with swallowing related to the event, then we're going to do that. But if there is no medical indication about inserting a nasogastric tube, we're not going to do that as well. It requires what? Specific medical indication. For example, dysphagia. And if they're gonna need to get nutrition, maybe medications to be crushed, then we can possibly administer that via the nasogastric tube. But most often, if a patient has acute seizure episodes, we're gonna have to temporarily put them in NPO. This is a best practice, especially in neuronursing, being a neuronurse myself. It's not advisable to proceed with feeding the patient, administering oral medications without clearing their swallowing ability. Okay? Always check for swallowing. Also do the dysphagia screen. It is highly advised anybody that has manifested any neurological issues, before we're going to proceed giving them any food, oral fluids, medications orally, they should be checked for their swallowing ability. We need to do dysphagia screening. It's how we do in neuro nursing. Okay? Always safeguard your patient from any possible choking episode. Okay? We usually would have alternatives when we are treating the patient with the seizure. Most of the medications that we'll be giving around this time will be through IV as much as possible. And again, we're going to have to continually check the patient's swallowing, not just once a day. Every shift, we're going to have to monitor their swallowing ability. If there is an improvement, then that's a whole lot better. And then we can notify the medical provider that our patient is safe to proceed with taking oral items. Okay? So back to our question. Our intervention should include what? Letter A, side rails, oxygen mask, and suction tubing. We are eliminating this, and tongue blade. Tongue blade is supposed to be used way back, like how many years ago was that? Maybe 40, 50 years ago. If you probably have an access to an old nursing book, probably you will see the use of the tongue blade during a seizure. Yeah, let me know if you can find a very old nursing textbook that would contain the use of a tongue blade in the nursing intervention. You probably would see that, but not anymore. We're not putting anything in their mouth in a seizure episode, and this is no longer part of our seizure precaution. Not indicated for seizure precautions. Okay? Only A, C, D. All right, let's move on. Number 9. While completing medication reconciliation for a patient with chronic cancer pain, which medication should concern the nurse the most? Is it A, amitriptyline 50 milligrams at bedtime, B, ibuprofen 800 milligrams 3 times daily, and C, oxycodone 80 milligrams twice daily, and D, meperidine, which is 25 milligrams every 4 hours? What do you think would be that medication that the nurse should be concerned about? And this is going to be related to the seizure as well. While completing the medication reconciliation for a patient with chronic cancer pain, which medication should concern the nurse the most? Is it the amitriptyline, 50 milligrams at bedtime, or is it the ibuprofen? Or is it letter C, oxycodone, 80 milligrams twice daily? Or the letter D, meperidine, 25 milligrams every 4 hours? I've included this type of questions because this is going to be part of the assessment of your patient with a history of seizure. So I want to test if you are able to determine what medication can possibly complicate into a seizure. Okay, let's try to eliminate letter C first. What is letter C? Oxycodone, 80 milligrams twice daily. Guys, this is a potent opioid analgesic. Okay, this is going to address the patient's pain, especially if they have moderate to severe pain. Again, the oxycodone is intended to treat the moderate to severe pain, especially in cancer. All right. Now, do you think that this is going to be an issue with the patient? I doubt. It's not really known to cause seizure into this patient. What about letter B, ibuprofen? This is an NSAID, right? Okay. And so it is an NSAID. This is going to be useful in treating the patient's mild to moderate pain. And it's not known to cause any seizure in a patient. Now let's identify amitriptyline. What do you think about amitriptyline? This is a what? A TCA, a tricyclic antidepressant. Tricyclic antidepressant that is going to be used as a pain reliever, especially for chronic pain, can be used or prescribed for chronic pain, especially in cancer, neuropathic type of pain. But it is not known to cause seizure. The medication that is known to cause seizure is the Demerol meperidine, and that is why it's no longer as popular as before. And look into the frequency here, 25 milligrams every 4 hours. This is contraindicated in this patient with chronic pain management, especially cancer, okay? Contraindicated. Okay, contraindicated in chronic pain. The Demerol is only useful for acute use, okay? And when the medication is metabolized, this is going to toxic. It can accumulate in the body when it's prolonged, when it's used for long term. Accumulation in the body if there is going to be prolonged use. So this is not going to be advisable. It can lead to nervous system toxicity. CNS toxicity, which is going to be manifested by seizures. So that is why it's no longer popular compared to the olden days. Meperidine is not used widely this time, and it's not supposed to be used for chronic pain as well because of its neurotoxic effects. It can accumulate in the system, causing the seizure. So the answer here is letter D. All right, let's move forward with number 9. After receiving the shift report on 4 patients undergoing substance use treatment, which patient should the nurse assess first? Is it A, a patient newly admitted for alcohol use treatment who last drank 2 hours ago? B, a patient agitated with nausea, vomiting, and diarrhea, withdrawing from heroin? C, a patient with tremors from benzodiazepine withdrawal who last used 4 days ago? And 4, a patient being treated for cocaine addiction who is irritable and disoriented with a pulse of 112 beats per minute. So you are the nurse. After receiving the shift report on all your patients, so which one of your patient you should see first? What do you think? Who of the following patients you should see first? I'm seeing letter D, patient treated for cocaine addiction. I'm seeing a lot of D's. There is one B, there is A. Good, I'm seeing a variety of answers. A, B, but mostly D. All right, let's tackle letter A. What about letter A? A patient newly admitted for alcohol use treatment who last drunk 2 hours ago. What do you think about letter A? Well, when we are talking about alcohol withdrawals, usually it will start alcohol withdrawal. It can start 4 to 6 hours after the last drink. After the last drink. Oh boy, my brain is somewhere else. My hand cannot catch up with my brain. After the last drink. 4 to 6 hours. So our patient is a newly admitted for alcohol use treatment who last drunk 2 hours ago. So still out of the window, right? Not the person to see first. 4 to 6 hours is our usual start, the onset of alcohol withdrawal. Guys, I'm just going to give you an idea of a person with alcohol withdrawal. It's no fun. I probably have treated maybe 200 patients with alcohol withdrawal symptoms in a medical surgical setting. It's no fun. No fun. Never encountered that in my life before. Never in the OR. If you're going to deal with a patient with alcohol withdrawal symptoms, usually it will be worse during the 18th hours up to the 24 hours since the last drink. This is the time that they're going to really be confused, disoriented, combative. But let's say for the first 24 hours, they might be agitated, maybe kind of like nervous, but not as disoriented when they reach into that 18th to 24 hours, right? So the first early hours, 4, 6 hours, 12 hours, they're fine. They're with it. Maybe slight confusion, disorientation, but overall, they're not that combative compared to the 1 day old or 2 days old alcohol withdrawal. Those are the worst patients ever. You're going to encounter hypertensive crisis, plus you need to deal with the seizure. You're going to have to deal with electrolyte imbalances, a lot of replacements because of the malnutrition. So many things that will be involved. But in this scenario, we're eliminating letter A because it is a fresh patient. Last drink was 2 hours ago. So we're not going to worry about this patient yet. What about letter B? A patient agitated with nausea, vomiting, and diarrhea, withdrawing from heroin. What do you think about heroin withdrawal? I know this is going to be uncomfortable. It will be distressing. The patient will have the nausea and vomiting. These are the distressing manifestations of the heroin withdrawal. But these are not life threatening. Not life threatening compared to the letter C, which is the answer. Okay. Our patient with a heroin withdrawal with just these symptoms, it's not life-threatening compared to letter C. So what is in letter C? Benzodiazepine withdrawal who last used 4 days ago. So this is pretty much similar to the patient with alcohol withdrawal as well. This is going to cause so many life-threatening problems. So what do you think? This can lead to seizures. That is the topmost reason that we need to assess this patient first. Because of the seizures, there's also agitation. What else? Delirium is another one, which is basically the same with a patient that had alcohol withdrawal symptoms like 2-3 days. Also, their cardiovascular function will be unstable. They will become hypertensive as well. Unstable hemodynamics. Okay. So our answer here is going to be letter C. Last used 4 days ago. So for those patients that have been using lorazepam, Ativan for chronic, again, those medications are not supposed to be used longer than 2 months in the textbook in pharmacology. These kinds of medications are not supposed to be taken longer than that because of its addictive properties. Okay. But you will see a lot of these patients using this long-term, years, taking these lorazepam at home. And again, if they're going to abruptly discontinue taking this drug, it can lead to the seizure episode. Okay, it is life-threatening. Now let's talk about letter D. A patient being treated for cocaine addiction who is irritable, disoriented with a pulse of 112. Again, this is quite similar to the heroin addiction as well. These are going to be uncomfortable withdrawal manifestations, tachycardia. Someone that needs to be monitored, but still not life-threatening compared to letter C. It is distressing again, disoriented. They can potentially become combative as well. But when we are comparing the severity of the manifestations, our C is of our high priority. Okay. Letter C. The seizure. The hemodynamic instability. That's the main reason why we need to assess our patient in letter C. Let's talk about number 11. While caring for a patient with left-sided lung cancer, which finding should the nurse prioritize when reporting to the healthcare provider? Is it A, hematocrit of 32%, B, pain during deep inspiration, C, serum sodium level of 126 milliequivalents per liter, and D, reduced breath sounds on the left side? Which finding should the nurse prioritize when reporting to the healthcare provider? The scenario is on a patient with left-sided lung cancer. Be careful in choosing your answer based on the scenario. So will that be hematocrit of 32%? Is it pain during deep inspiration? Or is it C, serum sodium level of 126? Or D, reduced breath sounds on the left side? What would be the best answer? I'm seeing lots of C. Let's tackle letter A first. What's in letter A? Hematocrit of 32%. This is reflecting anemia. Could be delusional type of anemia, or maybe just anemia caused by, who knows, maybe chemo or maybe radiation, right? But is this something that you will prioritize comparing with the other options like sodium level 126? Maybe not. We are going to continue monitoring the patient. So our action here is to continue monitoring the patient. We're not going to neglect this patient. We will monitor this patient. All right. She is not, or he is not manifesting life-threatening emergency. Eliminate that one. What about letter B? Pain during deep inspiration. Pain with a deep inspiration. I'm just laughing because I'm seeing some changes in the answer. Pain during deep inspiration. What is this? Well, this is going to reflect what? Possible pleuritic chest pain. During the inspiration, the pain comes on. So this is a common manifestation in lung cancer. All right. And it will also be associated with other complications, maybe pleural effusion. Again, these are complications. I didn't say that this is part of the scenario. So just putting the info right there. Pleural effusion can become a complication, or let's say inflammation. That's one thing. All right. So will this require immediate call to the medical provider when this is expected? Probably not. Eliminate that one. Now let's tackle letter D or letter C. Let's talk about letter D. Decreased breath sounds on the left side. Well, unfortunately, guys, our scenario is on the left side cancer. This is going to be expected. If it said diminished or reduced breath sounds in the right lung, then I would select that. But here, we have a problem already. Left-sided lung cancer. This is expected manifestation for this patient. And because it's caused by, of course, maybe the tumor growing, obstructing the airway, it can compress the lung tissue. And we're going to not neglect this one. We're also monitor. Okay? We are going to monitor continuously, but not going to require any call to the medical provider. This is an expected manifestation. Serum sodium level of 126. Yeah, that is already low. All right? 126 sodium level can do a lot of things in a patient. All right. Hyponatremia. Remember that our value should be within 135 to 145 milliequivalents per liter. Okay? Maybe the reason that the patient has hyponatremia, maybe the patient had developed some complication, maybe now with a syndrome of inappropriate antidiuretic hormone. And this is going to be the result of the treatment, okay? This can possibly lead to the SIADH. And we know that there is going to be abnormal reabsorption of the water fluids into the vascular system. It can lead to cerebral edema. Cerebral edema. It can cause seizures. All right. Our patient requires replacement of sodium. They're going to end up possibly with fluid restriction in order to balance the fluid and the sodium level. That's the next step that we should be doing. But again, when we are going to prioritize the patients, or the options here, we're going to call when the patient's sodium level goes below with this level, 126 milliequivalents per liter, especially in the case of a lung cancer. There is a possibility that they are already developing the syndrome of inappropriate anti-diuretic hormone. It needs immediate treatment because the patient will end up with cerebral edema. All righty, who got the correct answer? Letter C, we have Yakima Taylor and Chika and also AJ Ike. Who else? Charity, Ozzy's World, Anita, Ray, Roberta, and Melrose, and Boss Babe. I'm not quite sure if the rest of the C's are on the same test item though. But good for you that you had answered the correct option. Number 12, after a shift change, which patient should the nurse assess first? Is it A, patient with potassium level of 5 milliequivalents and abdominal cramping? B, patient with sodium level of 145 milliequivalents per liter who is thirsty? C, patient with magnesium level of 1.1 milliequivalents with tremors and hyperactive reflexes. Letter D, patient with a phosphorus level of 4.5 milligrams per DL and soft tissue calcium phosphate deposits. After a shift change, which patient should the nurse assess first? Is it A, patient with potassium level of 5 milliequivalents per liter, abdominal cramping? B, patient with sodium level of 145. C, patient with magnesium of 1.1. D, patient with phosphorus level of 4.5 milligrams per DL and soft tissue calcium deposits. Calcium phosphate deposits, rather. All right, let's start eliminating. Letter A, patient with potassium of 5. Again, our value reference is going to be what? 3.5 to 5. Oops, not 50, but 5.0. Okay. 5 milliequivalents per liter. Our patient is borderline normal, but on the high side. I'm not going to prioritize this patient. Nothing to worry about this patient yet. What about letter B? Patient with sodium of 145. It is slightly above the range. Actually, it's not slightly. This is still within normal limits. 135 to 145. We are still safe on the upper end. So for those two patients, we're not going to neglect them. We are not. We will monitor them because of their upper normal limit. Okay? Monitor these two patients, but it doesn't mean that we are going to assess them right now. Okay? Still need to monitor them. What about letter D? Patient with phosphorus level of 4.5 milligrams per DL and soft tissue calcium phosphate deposits. Well, our patient's phosphorus level, normal value is what? The normal value of phosphorus is going to range from 2.5 to 4.5 milligrams per DL, or in milliosmoles, it can be 0.81 to 1.45 milliosmoles per liter. So we are still safe in the range. Okay? Higher end, yes, we'll monitor the patient, but not going to be the first patient to be assessed. Our patient who has a MAG of 1.1 milliequivalents per liter, ooh, what is the normal range of the magnesium? Serum. Oh boy, I'm thinking about IV already. What do you think is the normal magnesium level? Well, if we are using the milliequivalents per liter, our range is around 1.7 to 2.2 milliequivalents per liter, our patient is way below the range. And as we know that the patient is already what? With tremors and hyperactive reflexes. Graciously, thank you for the value. Yeah, it can slightly vary from one laboratory to the next. Yeah, yours is also correct. I've seen that as well. But here we are looking for a value that will predispose the patient to developing seizure. Okay? So the patient with hypomagnesemia, they're going to have 1.3. What is your source? I want to know what textbook you are referring, Mariflor, because even Saunders I don't trust anymore. Yeah, there is so many errors in Saunders that I have noticed, so I stopped using that as my reference book for reviewing my students. So let me know where you got that 1.3. That is quite low for a magnesium equivalent, milliequivalents per liter unit of measure. So let me know if that is in other unit of measure. Okay, so our patient that may have hypomagnesemia can, already hyperactive reflexes and also tremors. They are known to develop or to progress seizure episodes. They are known to do that. Also cardiac dysarrhythmias. So why we are going to prioritize this patient? Because they are going to be predisposed to the development of seizures. Hyperactive reflexes are already the precursors. Okay, so yeah, be careful with the Google as well. Be careful. There are so many errors, even in, be careful in when you're looking into the ProProfs, even Quizlet. There are so many questions there that are so erroneous that I've found. So don't rely on those sources because those are uploaded by just regular people, not really academician. And so they're just relying on some informations that are not based evidence by evidence. And so you got to be careful, guys, with your value. I'm warning you with Saunders, there is a problem, especially with the new textbook, the new version. The value there for their calcium is on the high side. Even with the Archer, they have a higher range on the calcium. But if you're going to use the Lippincott, I would rather trust that one because they have the similar range with the medicine textbooks. So be careful, guys. Do not rely on those sources that I had mentioned. I've checked back to back, compared with other reviewers. I always go back to the fundamentals and use medicine textbooks. If I'm like confused, why is this value so different from other reliable sources? Be careful. Even reviewers have erroneous information, so be careful. And so our patient, again, will be at risk to developing the seizures. All right. Now let's talk about number 13. Which information should the nurse urgently communicate to the healthcare provider for a patient with possible SIADH? Letter A, recent weight gain of 10 pounds. B, shortness of breath. Yes, I've seen so many errors. I have a collection of screenshots already, and I'm trying to communicate with Elsevier. I've already complained with so many textbooks as well in the past. They got back to me, but not yet with this newer version. Which information should the nurse urgently communicate to the healthcare provider for a patient with possible SIADH? A, recent weight gain of 10 pounds. B, shortness of breath with activity. C, urine specific gravity of 1.024. And D, serum sodium level of 116 milliequivalents per liter. So again, guys, please do not be confused. Stick to what you know would be safe for this patient, okay? All right. Number 13, what do you think would be urgently Communicate. What information you should communicate urgently to the healthcare provider, especially with a possible SIDDH? Is it recent weight gain of 10 pounds? Would that be SOB with activity? Would that be specific grab of 1.024? Or this one, letter D? Oh, wow, wonderful. I'm seeing lots of letter D, guys. You are perfect. You are correct. Our patient really has severe hyponatremia. Yeah. Let's try to eliminate letter A first. What is in letter A? Weight gain is a common manifestation of SIADH. It is expected manifestation. And it doesn't mean that I say expected that you will ignore. No, I'm just saying that this is an expected manifestation. You will continue monitoring. Okay? Please do that. Do not ignore. Keep monitoring the patient and notify for any associated manifestations. If they're going to end up with other manifestations like neuro changes, respiratory changes, then I would immediately notify the medical provider. But just the 10 pounds increase, I would keep monitoring this patient. I will mark this as incorrect this time. What about B? Shortness of breath with activity. It said with activity. Without activity, is there shortness of breath? Maybe not. So I will keep monitoring this patient as well. This is a significant finding. We will keep monitoring this patient. Yeah, this is going to be a possible problem if the shortness of breath will occur even if at rest. Okay? What about letter C? Urine specific gravity of 1.024. The range here, as we know, guys, please don't forget about the 1.010 to 1.030. Our patient is on the higher end. It is not going to be a indication that the patient has SIADH. This is not going to be a manifestation of ADH. But as we know, if the if the specific gravity goes higher, remember, if the specific gravity goes towards a higher end, it simply means that it is going to be concentrated. Okay? Higher specific gravity number is concentrated. The concentration of the urine is going to be higher if the specific gravity is higher. The number is higher, closer towards the 1.030. If the number is closer to the lower end, then simply means that the specific gravity or the urine is somewhat diluted. And we are going to expect the dilution. Is it diluted? No. We're talking about the SIADH, right? Let me just clarify here myself. So what is wrong with the SIADH? That is the question. I know, Mary-Flo, right? You're probably going to be a master of this one. SIADH. There is excessive secretion of what? Hormone, anti-diuretic hormone. So what is going to happen here? The patient will be conserving way too much water. It will not waste any water. It will conserve more water. So it will reabsorb lots of water. Reabsorption is going to be increased. So our patient will end up with what? Not diluted, but going to be a concentrated urine. But that concentration will only give us an idea that, hey, this is an expected finding. Okay, nothing to worry about the specific gravity because this is expected of SIADH. The urine will tend to be much more concentrated because the body is releasing way too much antidiuretic hormone. So it's just an indication, hey, yeah, this really confirms that the patient has IADH. However, if you're going to compare it to the sodium of 116, hyponatremia, the dilution of the sodium in the body, what do you think? Again, what do you think can happen to the brain cells? Let me check. The brain cells will become swollen. Swelling of the brain cells. This will lead to what? Serum sodium. The curve. Brain cells will become swollen. It will now lead to what? Increase in the ICP and also seizures. Okay? That is the reason why we are going to watch for this patient with hyponatremia when there is less tonicity in the bloodstream. Okay? Diluted blood. Sodium level of what? 116 milliequivalents. All right? And supposing this is going to be our brain cells, there is going to be shifting that can occur here from the vascular compartment. Fluids will go into the brain cells. Yeah. Can cause swelling to the brain. Cerebral edema can occur, can lead to ICP increase and seizures. All right. So correct answer is letter D. Let's move forward to the next question. Again, guys, we are inviting you to enroll to our NCLEX program via our website. Please visit Stancoast, NCLEXcoaching.com, and also check the description box below for more information. All right. Thank you. Let's talk about number 14. A patient on phenobarbital for seizures reports drowsiness and has serum drug level of 30 micrograms per ml after 2 weeks. What should the nurse advise? A patient on phenobarbital for seizures reports drowsiness, serum drug level of 30 micrograms per ml after 2 weeks. What you should do in this scenario? Is it A, contact the provider to change to once daily dosing? B, increase the dose to 3 times daily to reduce drowsiness? And C, sedation is expected and will decrease over time? And D, the drug level is high, the provider will likely lower the dose. Okay, so our patient has been using the phenobarbital for 2 weeks, and the serum level of the phenobarbital is 30. But he is also reporting drowsiness. What you should advise to this patient? Is it contacting the provider to change to once daily dosing? Or B, increase the dose to 3 times daily to reduce drowsiness? Or C, sedation is expected and will decrease over time? Letter D, the drug level is high, the provider will likely lower the dose. What do you think? All right, let me start rationalizing this time. What about letter D? The drug level is high, the provider will likely lower the dose. Let's take a look into the drug level of 30. Well, what medication is this? Yes, we are talking about phenobarbital. Okay. So our value here in the blood should be within 15 to 40 micrograms per ml. Maybe there will be slight variations with some other medical references. So we are still in a safe range. Our patient's value is 30. And so if you are answering letter D, this is wrong because the level is not high yet. The patient's level is still within the normal range. So this is incorrect. What about letter C? Sedation is expected and will decrease over time. You think that the sedation will decrease? Well, I doubt that. The sedative effects of the phenobarbital will be common, but the process can really take several weeks to months. Decrease over time, we are talking days, not days, guys. This will take a while for the reduction of, let's say, the sedation side effect. So this will take weeks to months to process. But the issue here is drowsiness. The drowsiness that we are talking about could be daytime drowsiness, and we probably would not help this patient if they are active with their lifestyle. The daytime drowsiness will not be helping them. So probably the dosing schedule will be adjusted. It probably would be given. Maybe the frequency will be lowered. And so this is not going to be the best answer this time. Now, take a look into the letter B. Increase the dose to 3 times daily to reduce drowsiness. Do you think that increasing the dose will combat the sedative effect of the medication? I doubt. So, increasing the dose of the phenobarb will increase the sedative effect. So we are not going to select this one. Will further increase sedative effects. All right. So we are eliminating that one. Very good. You answered letter A. There is going to be this one. A, contact the provider to change to once daily dosing. All right. The patient's blood value of the phenobarbital is still safe. We are in the range. We just need to change the once daily dosing to reduce the drowsiness. That would be the most accurate conversation that should take place with the medical provider. Okay. All right. Very good. Very good. I'm seeing a lot of A's. Now let's proceed to number 15. A patient with partial seizures is starting oxcarbazepine and is also on furosemide and digoxin. Don't you hate that when they start giving all these different medications in the mix? Which patient statement shows correct understanding? Again, the statement said, a patient with partial seizure is starting oxcarbazepine and is also on furosemide. But the question did not indicate if the patient is already on once a day. Okay, let's go back. Let's address that question graciously. All right. Yes, a patient in the phenobarbital for seizure reports drowsiness. It did not. So what would be the safest option that is already given in this scenario? We are only going to answer the test question as it is. I know that you are going to be ideal, right? You really want to be ideal as much as possible. And so when you're going to be the test taker, don't really read into the question that you're going to end up fighting against the test question itself. What you're going to see in the situation is to make sure you're going to have to, hey, I think this is not the most ideal scenario that I am reading right now. And I'm just going to select the safest intervention, the safest assessment tool that I should provide for this patient. You will be tested in the NCLEX like that. Not all in the scenarios will state the very ideal setups. Sometimes there's going to be some errors in the statement, like not deliberate. It's not like an error that is committed because there was a wrong construction of the sentence. It could be a deliberate entry of that error. okay? Just similar to a real situation in the clinical setting, okay? And so with this question, it stated a patient phenobarbital for seizure reports drowsiness and has a serum level of 30 after 2 weeks. I know that there is no frequency given in the situation, but it is asking you this time, what would be that advice? Or maybe a statement that you should be giving or informing or notifying the doctor about. Will this be letter A, B, C, D? And we have already cleared those others, right? Like letter D, level is high. That is already erroneous. So we are just going to eliminate those distractors until you're going to find the most ideal, or at least the best answer. Even though it's not ideal, you're going to have to operate. You have to work around the scenario, okay? So according to the options, there's no other correct answer other than letter A. Contact the provider to change to one's daily dosing, because possibly, we don't know, maybe the order was twice a day with a breakdown of the dosing. So this can really cause them to be drowsy during the daytime. If you had answered letter B, it really will not help out. I don't see the question. What do you mean I don't see the question? I'm not quite sure, Tiramaj, but like I've said, you're going to have to eliminate those distractors that will really not address the question being asked, okay? Even though there is some limitation, maybe the scenario is so incomplete, you're going to have to try your best to really select that safe answer, okay? So that is my only advice for you, because I've seen so many questions like that, even in so many sources. Lippincott, I've seen that as well. What else? UWorld. There's so many issues with a test question. Maybe it is deliberately done that way, but it is going to test you how you're going to work around the scenario. That is the reason, okay? It's not a unconscious construction of the statement or unconscious, what do you call this? It's not, it's actually deliberate, maybe non-ideal type of construction of the sentence. And this is what I've noticed in so many questions as well. So it will just test you if you can work around it. That's it. All right, moving forward with number 15. A patient with partial seizure is starting oxcarbazepine and is also on furosemide. So what do you need here? Is it A, I might need a higher dose of trileptal? B, rash and itching are not serious side effects. C, I should report nausea, drowsiness, and headache. And D, I should use salt substitutes instead of salt. So let's go back to this question. Partial seizures, oxcarbazepine, on furosemide, and digoxin. So your task here is to identify the four statements and identify which of those statements show understanding about the therapy involving those three medications. So what is your answer? I'm seeing Mary answering C. What is that? I should report nausea, drowsiness, and headache. Okay, that's a good sign. All righty. Oxcarbazepine. Remember about the oxcarbazepine? This is actually similar to the carbamazepine, right? Carbamazepine. What do you think about this drug? What do you think would best fit into the profile of the drug? So you're going to look for those statements that may reflect the side effect, or maybe, I don't know, manifestations that might signify that they're already having the hyponatremia or maybe the imbalances. So the carbamazepine, remember that this is one of the sodium channel blockers, right? Remember? in our discussion earlier, it can lower the sodium. Okay. So what do you expect? There is going to be hyponatremia. So what we're going to look for are those manifestations that might be associated with hyponatremia. Let's take a look on letter D. I should use salt substitute instead of salt. What do you think would be high content in salt substitute? Do you remember about the rich electrolyte that you can find in the salt substitutes? What do you think? Remember that they are high in potassium. High in potassium chloride. Yeah, remember about the potassium? They're the best of enemies. Sodium and potassium. If you're gonna sense that the patient is, if they stated I should use salt substitute instead of salt, the more that they're going to end up with hyponatremia. This will exacerbate the manifestations. All right, we are eliminating that one. What about letter B? Rash and itching. Number 14. Let me go back. I can't remember. The correct answer for number 14 is letter A. Contact the provider to change once daily. Okay. Oh, it's already 3:40. I'm sorry, guys. It is already late in the US. Okay. So this will be our last question this time. And so we're going to have to deal with the manifestations of the hyponatremia. So what do you think we should be doing? Are you going to check off on A, I might need a higher dose of trileptal? Does that mean that the patient has understanding about the therapy? What do you think about that? Letter A, higher dose of trileptal. This is incorrect because the dose adjustment should be based on the assessment, clinical assessment by the medical provider, and it will be dependent on the therapeutic drug monitoring. So it is not going to be based on the patient's assumption. Drug dose adjustment is not based on patient statement. It is not safe. It should be based on the clinical assessment and also the drug monitoring. Should be based on drug level and also assessment findings. It should not come from the patient's own idea. I might need a higher dose of trileptal. This is incorrect. What about letter C or letter B? Rash and itching are not serious side effect. That is incorrect as well, because as we know that the presence of rash is a sign of serious allergic reaction. Serious allergic reaction. Okay, and we should report this to the medical provider promptly in order that they can evaluate the patient. So our correct answer here is letter C, which is going to be, I should report nausea, drowsiness, and headache, because these are signs of what? Hyponatremia. And if there is hyponatremia, this can predispose them to develop, or this can precipitate them to develop the seizure episode. All right. So our answer here is to check that statement. I should report nausea, drowsiness, and headache, because these are manifestations of hyponatremia, and we need to address this right away so we can start replacing or stabilizing the patient's sodium level before seizures can occur. Okay, so I hope that you're learning today from this topic. It is quite heavy, especially with seizure. The pharmacological treatment is already heavy. And so If you are not quite comfortable yet with the topic, you please review this video, and also if you have any questions, let us know so we can address those. And don't forget, sign up to our NCLEX course in our program. Drop by the website stancoast.nclexcoaching.com. Also to inquire, you can drop us a message and also check onto the description box below so you can know more about the NCLEX course that we have. We have updated our library already, and so expect some more to come in the future. And so that's it for today. I thank you for your participation, and I hope that you have learned, and I'll see you again at 9 p.m. tomorrow, or whatever is going to be discussed here. So thank you again. You have a great night, you have a great morning, or wherever you are, you have a great afternoon. All right, thank you, and bye-bye.